Salam alaikum, sabah al-khair tout le monde. Ma première phrase sera en français pour les personnes qui voudraient suivre ce webinaire en français. C'est très très simple. Il y a un bouton vers le bas où vous pouvez cliquer sur FR. Je répète, pour les personnes qui voudraient suivre ce webinaire en français, il y a un petit bouton vers le bas où c'est marqué FR et vous allez pouvoir suivre tout le webinaire en français. Maintenant, il est temps de switcher en anglais. So, good morning, everyone. Hope you are doing good. So sorry for this short delay and welcome to this exciting international e-conference on training and simulation for patient safety PS 2024. It's an honor for me to be here with you, bringing experts and innovators from all around the world in the field of medical education, simulation, and patient safety. My name is Mohammed Mohawi. I'm the head of Morocco SIM, which stands for Moroccan Society of Simulation in Healthcare. We are so proud of the progress that we have made in advancing healthcare. But today's session will further inspire, challenge, and engage us to finding better solutions for tomorrow's healthcare challenges. So let's embark in this journey committed with excellence and collaboration. And it's time to give the stage to my colleague, Mohammed Darwish. So Mohammed Darwish is the youngest member of the National Board of Morocco SIM. And by the way, he is the coordinator of the Morocco SIM Club Junior. So, Si Mohammed, stage is yours.
Thank you, Professor. Good morning, everyone. My name is, as you might have guessed, Mohammed Darwish, and I'm honored to be your host for today's event. I'm gonna be responsible for making the transition between the sessions. On behalf of Morocco SIM, it is my pleasure to
Welcome to
welcome you
the Training and
to the
Simulation for
International
Patient Safety webinar.
e-conference on training and simulation for patient safety. Today, we are bringing together leading experts from across the globe to explore the latest advancements and best practices in healthcare simulation. Our program is designed to foster the exchange of knowledge and skills, all with the shared goal of enhancing patient safety. Thank you for joining us for what promises to be a day of insightful sessions and collaborative discussions as we work together to drive innovation and excellence in healthcare education. To kick off our program, it is my pleasure to introduce Dr. Ingrazia Pierluigi from Italy, President of Sesam, founder and editor-in-chief of SimZin, and scientific director at Centro di Simulazione, CISAI. Dr. Ingrazia is a highly respected leader in the field of healthcare simulation with extensive experience in spearheading educational programs and research initiatives across Europe and beyond. As president of Sesam, he plays a pivotal role in advancing the use of simulation to enhance patient safety and healthcare education globally. Please join me in welcoming Dr. Ingrazia, who's gonna present his welcome address with a video. Thank you.
Welcome to the Training and Simulation for Patient Safety webinar, proudly hosted by Morocco SIM. Today, we embark on a comprehensive exploration on how simulation training enhances patient safety, engages with the multifaceted challenges of healthcare, and pioneers new educational methodologies. The sessions, led by distinguished national and international experts, will bring you to the critical roles that simulation plays across various domains of healthcare. And I am very pleased and honored to bring my greetings of the Society for, and those of the Society for Simulation in Europe, SESAM, and not only to the national and international panelists, but especially to all those who are following this valuable event. I believe that the moments of discussion like this are necessary to create the culture of risk reduction that we all believe in and we are working to grow. The common thread today will be precisely patient safety and the role that training has in these regards. And therefore, let me mention the global consensus statement on simulation-based practice in healthcare. My friends and the immediate past president of our society, Francisco Matos, will tell you with more in details about it afterwards at the end of this webinar session. But let me briefly tell you what it's all about. It's a landmark document advocate for standardize high-quality simulation practice worldwide and underscore the critical role of simulation in advancing healthcare education. It serves as a guiding framework for both current practice and future advancement in the field. It's a unified declaration crafted by representative from 50 national and international simulation societies and networks distributed across 67 countries to advocate for a global and enhance the implementation of simulation healthcare. The global consensus statement represents a key strategic pillar for CESAM, promoting the integration of healthcare simulation across education, research, and clinical practice. Simulation has emerged as a critical solution, and the consensus underscored several critical areas where simulation can significantly enhance healthcare delivery. I encourage everyone to read it and make it known to your decision makers. I do not want to take up any more of your time. The agenda is already complex and busy enough. I congratulate Morocco team for this initiative that reflect one of the mission of any scientific society, in my opinion, namely the exchange of information through meetings. And I greet you with the wish to see you again in February during the HTIS 2025, where I hope we will have the chance to meet you all in person. And and then again in Valencia in June in next year for our annual CSAM annual meeting. So greetings again and good work to you all.
Thank you, Dr. Ingracia, for this welcome address. Very, very important, very brief, and thank you for that. And we can't wait to meet you in the HAIC, one of the biggest events of 2025. Please fasten your seatbelts as we're gonna fly from Europe to North America, precisely in Boston, in the USA. Our next speaker is Dr. Lon Setnik, Director of the Clinical Program at the Center for Medical Simulation, where he's playing a key role in advancing clinical simulation courses. He also serves as an attending physician at Concord Hospital with a deep commitment to simulation education. He has led numerous programs ranging from work with the NH, Army National Guard, to hospital-based teams managing trauma, stroke, and cold blue scenarios. Please help me welcome Dr. Lon Setnik, who's gonna present his welcome address through a video.
simulation of a difficult airway. A team was trying to manage a burn airway, and they were faced with a decision, and it's a key moment in the development of an individual and team skill. Do I stop what I'm doing, abort, and try a different process for managing that difficult airway, or do I persist? The magic of simulation is that we can stop time, we can coach, we can have redos, we can rewind, and we can help people with deliberate practice so that they're ready for the most difficult moments of their careers, and they've had a chance to rehearse them without harm to real patients. Simulation also helps us as supervisors to tolerate the imperfections of our learners and to allow them the gift of failure as part of the learning process. If this were a real patient, we wouldn't allow them the failure. But in simulation, we can take a step back and let them learn through imperfection. My name is Lon Setnick, and I am the Director of Clinical Programs at the Center for Medical Simulation in Boston, Massachusetts. And I'm here to introduce the 2024 Morocco eSIM Conference. My request for you is to process the techniques that you're going to learn about today, but also think not only how am I going to use these in simulation, but how can I take the values of simulation and move them outside of the sim space so I have a bigger impact on the healthcare systems and
de plus grande
organizations that
ampleur
I touch.
sur les systèmes
Because the values
médicaux.
of simulation, demanding high-level work and mastery prior to touching real patients, needs to be paired with high regard for our learners. And those values should not only exist in simulation, they should exist within our health systems and our units. And so as you go through the day today, think, how am I going to use these ideas in my everyday practice in the clinical spaces? And how am I going to improve the world of healthcare, not just the world of simulation? Thank you for your commitment to learning, your commitment to making the world a better place, and welcome to the Morocco eSIM Conference 2024. Thank you, Professor Muhammad, for the invitation to get to talk to you all, and I hope you have a wonderful day.
Thank you, Dr. Lon Setnick, for your illuminating presentation, which showcases the importance of simulation and the value it adds to our life, not only on the hospital field, but even outside it. After the insightful introduction from our esteemed speakers, Dr. Ingrazia Pierluigi and Dr. Lon Setnick, we are now ready to move forward with our presentation. For our first session, Foundations of Patient Safety, it is my pleasure to introduce and hand over the session to the session chair, Professor Adib Ahmed Ghassan. Professor Adib is the Dean of the Mohammed VI Faculty of Medicine in Casablanca and the head of the Moroccan Society of Emergency Medicine. A distinguished medical educator and administrator, he has been instrumental in advancing medical education through simulation-based learning, greatly enhancing patient care and safety. His leadership and innovative approach have had a profound impact on healthcare training, positioning him as a key figure in the modernization of medical practices across Africa. Professor Adib, the floor is yours.
Thank you, Sir Mohammed, for this kind presentation. First, good morning to all. We are very proud to be here in this e-conference. Great thanks to our president, Mohawi, to bring this network and this valuable e-conference. This session is about patient safety, and as you know, safety is the first dimension of healthcare quality. In this session, we will have two speakers, Pekler Brad from New Zealand and Vijayanand Jamalpuri from India. And we will start with the first presentation from Pekler Brad about how to build a culture of safety in healthcare. Pekler Brad is the head of the New Zealand Association for Simulation in Healthcare. He's an emergency specialist and director of simulation of the Wellington Regional Simulation Center at CC. And for sure, patient safety is one of his most topics and research. Dr. Pekler Brad, the floor is yours.
Thank you. Kia ora, tēnā koutou, tēnā koutou, tēnā koutou katoa. It's a traditional Maori te reo greeting. I am an American, but I've lived in New Zealand for 15 years and have immigrated and am a Kiwi. And I'd like to thank the organizers for this. I'd like to thank the organizers for this opportunity to talk about this topic that's near and dear to me, and also Mohammed Mahoudi for inviting me particularly. And also I'd like to give thanks to Bar Coleman, who's the head of quality and safety at our regional center, as she helped me with this, put together this presentation. Just going to share my slides. Yeah. So I'm in New Zealand here at the bottom. It's evening for me, and the All Blacks are playing in the championship tonight against Australia, and we're ahead at halftime. I'm sure everybody's happy about that. Over here is my sim team. We all have pet Kiwis. And so dispensing with that, I'm going to start out with what is a safety culture. And this is sort of a definition that sort of works, I think. An environment that supports patient safety and enables staff to do their best work every day. And it's sort of a continuous journey that you have. And I'm going to paraphrase the basic assumption that we all use in simulation, that healthcare professionals are intelligent, capable, and care about doing their best and want to improve. No healthcare provider shows up to work wanting to make a mistake or hurt anybody. We all aim to do the best we can every day. And if you sort of think about that, that's a good place to start. So there are lots of different definitions. You heard Lon from CMS, right care person every time. Another definition from the Institute of Medicine, which actually I pulled this off of the Australasian College of Emergency Medicine, and they list these 6 different traits for providing patient care and quality. But policymakers may have a little bit of a different twist on this, and they conform to consensus guidelines. And I think defining what quality is to you and to your institution probably helps you achieve it, and that sort of makes sense. So how do you do that? And how do you create a culture of safety? New Zealand is a little unique in that there is no punitive tort law, meaning that there's no malpractice. We essentially, as physicians, police ourselves, which is maybe a little bit unique, and it's partly to do with the socialized medicine we have. And one of the things sort of that comes out of this is we want an open, just, non-punitive system that encourages transparency and accountability of the organization. And I'll talk to that a little more. But open reporting and review when things don't go as long, with frameworks that can address this within clinical governance. And what I'm going to try to sell to you today is to celebrate when things go right and find out why. And really, it's about systems, and we'll get into that. So if you are familiar with Professor Erik Hollengel, who's a Danish psychologist, who does a lot of systems management, performance and safety delivery, resilience, healthcare and engineering, and human reliability analysis. There's a YouTube video for The Secret of Safety. It's about an hour long. It's really worth watching. And he sort of divides it up into safety 1 and safety 2. And safety 1 is sort of this reactive, retrospective response and analysis to bad events. And this is the traditional idea that a bad event has happened and we try to prevent it from happening again. And there's a couple of problems with this sort of plan. And yes, it's great to learn from experience, but if the number of adverse outcomes is quite small, and so this is taken from his lecture, and you see that center gray area, which is the idea of safety, and you have these 3 events that are the sort of out of the norm, and these get a lot of attention, but they're not the norm. And I guess the greatest analogy, I think, to this is, how do you define a good marriage? Do you define a good marriage by looking at the causes of divorce? No, you look at what makes people happy. It just doesn't make sense. And this is sort of what most, or in the past, what systems have done. And so the idea was a reduction in variation to acceptable level of risk. And that leads into this idea of safety 2. And this is kind of a newer concept, and it's more of a glass is half full, a positive look at things rather than the negative side of things. And safety is a condition where, as much as possible, all goes well. And it's the ability to perform the required under varying conditions. And this is to celebrate learning from excellence. And why do things go right? That's really what we're looking at. And so this is the same graph as the previous slide, but what you're looking at here is that green area. And the question that we're asking is not the absence of safety, but it's the presence of safety. How do we stay in that green area? Yes, we understand that there will be times where things don't go as planned, but how do you stay in that area? And as an emergency physician, if I am shown an ECG and I diagnose a STEMI, and I get the patient to the cath lab and the cardiologist opens up the artery within 30 minutes, who gets the accolades for that? It's the cardiologist. If it's a trauma surgery, if it's a trauma and I run the trauma and the patient gets the right gets diagnostics and life-saving procedures, it's a trauma surgeon, right? No one knows that I did well. It only goes when I go wrong. But the better question to ask is, how did those things happen in place to let me get that patient to where it needs to be? And I think that's sort of the thing that we need to think about. So there's this idea of AI, appreciative inquiry, and this isn't artificial intelligence or advocacy inquiry in the simulation world. But this is an idea that you take a positive approach to organizational change by emphasizing the positive ideas, and encourage discussion and opportunities for individuals to share their vision and discover the untapped potential. This is the realization that organizations can learn from what already works rather than from what doesn't work. It's particularly when implementing better practices or new practices and transformations to focus on what organizations actually do good and want to do more of. Since what organizations focus on becomes reality, it's more effective and pay attention to this perspective rather than looking at the negative aspect of bad events. This slide is taken from the nursing literature, and on the left in the blue is sort of systems 1, and appreciative inquiry or systems 2 is sort of the one on the right there. And I'm not going to read those to you, but looking at these, what you're looking at is a proactive system, right? To focus on what you focus on is reality. And if you find out what works and you can work on that and make that throughout your systems, you're going to be much more successful. So this slide here is about where your system is. And, you know, the bottom left there is, yeah, it happened, no one saw it, but nothing happened, so it's okay. And it goes through the different steps that you transform into better healthcare, within being generative. And the idea that you want to prevent things from happening, or you're proactive in that. In reality, most places are somewhere between reactive and calculative. And that is sort of something that you want to strive to get. And this is where clever clinical governance frameworks came in to help facilitate this. In New Zealand, we have this idea of restorative practice, and this comes from the legal term of natural justice. And the idea is that you have two parties, one is the perpetrator, one is the victim. And the idea is that you want to come and settle this process in a process that is beneficial to both parties. The problem, and the part that makes us uncomfortable, is that in medicine, when something goes wrong, the victim is clear, that's the patient. But the perpetrator isn't one individual, it's usually a systems issue. And that is actually the difficult part. And we're still working through this, but this is sort of one of the things that we use in the background to try to plan and figure out when things go wrong and how to address them. So how do you get better, right? So education, teamwork, yeah, you'll have some analyzing of events, but these don't necessarily, or should not necessarily, be just bad events. They should be good events as well. And really, the money is going to be with systems evaluation. And how do we do that? Well, simulation is a reasonable way to start. And I am a SSIH accreditor and have been for more than 10 years. And really one of the most difficult accreditation, site accreditation things to get is systems. And because that is really the sign of a mature program or quality improvement program when it's integrated with the simulation service.
Yeah.
So some of the things that you would think about from the Institute of Health, their triple framework, it's actually a quintuple framework. When you're thinking about trying to define your specific institution system of or safety culture, pursuing the improving of patient experience, improving the health of all populations, and reducing the cost of healthcare, but also acknowledging, and this is sort of a newer concept, that actually you need to make the workforce feel valued and give them the ability to provide care. And also the idea of equity of care is also important. And this is where we come to systems integration. And I'm going to use system integration and systems engineering somewhat synonymously because they are quite related. But this is the idea of a planned, collaborative, integrated, iterative application of simulation-based assessment research, teaching activities with systems engineering and risk management principles, with the end goals being excellent clinical care, patient safety, and improved outcomes. Now, these are all things that really, that standardization that can happen through simulation, through testing, evaluation, and monitoring can actually prompt. And we're talking about transformational healthcare through simulation. How do you do that? Well, it's a partnership of all the people involved, and simulation is a tool or a lever of change. And there are lots of different complementary tools and technologies. So these would be things like your IT system, your different processes and guidelines, new technologies, including artificial intelligence, the people that are involved, the teams that are involved, the design, the ergonomics, and of course, systems engineering. So systems engineering, I think, is just worth mentioning and defining clearly. And this is the interdisciplinary field of engineering focused on how complex projects should be designed and managed. And this is not necessarily unique to medicine. It has to do with all different processes. And these in this list is not exhausted, but things like logistics, coordination of teams, modeling, using technology and AI, machinery, and human factors. And this field really develops and assesses work processes and simulation or tools to handle these projects, and overlaps with both technical and human-centered disciplines. And, again, many fields use this, and I think that this is an important thing. And so why is it important? Because no one's got any money these days, right? How many times have you asked for money for a program or for things? And not a lot of money or resources get spent on quality improvement or making or going towards that generative process that we would strive to be. And we know that lots of morbidity and mortality are due to systems errors. And so where does that money come from? And this is a statistic from the Americans, but less than half of patients are supposed to receive the best practice in the U.S. And so, if you start from a patient-centric principle, the safest care is different from the highest value care. And the highest value care is sort of the goal of an optimized system. And really, this can only happen from top-down understanding. And for those of you who work in patient safety or quality, trying to get a bunch of clinicians and a bunch of operation managers in the same room is really difficult. And like they can't operate in silos. They have to work together in order to do this clinical support and deliver the best care on a daily basis. And so put this video up here, and I mean, this is sort of the point.
Daniel Smith, Carrier, Mike Barno, Jackman, Stan Doolittle, and the Fueler, Justin White. These 5 men were all together a year ago. Silence not so far. Harvick says he needs help on entry and a little bit more help on drive off.
Here's the anatomy of this pit stop. Watch the fancy footwork on the fueler. Now, all he can do is fuel the car, but for safety reasons, they do allow him to help guide a tire back to pit wall like that.
Right. So how many people have had their tire changed in all 4 tires changed in 20 seconds? In order to get to that level of perfection and that level of cohesiveness, there are lots of things that need to be taken into account. And so you have your patient, and then you have the frontline providers, the people at the coalface who are taking care of them, and they are supported by the organization, which then is supported by the environment and the government and the policy and framework makers. And I think that's sort of the way you want to think about how you should make some of these decisions. And the idea that you have a safety culture, there's this hypothesis, the brand hypothesis, this idea that you have the patient and the process, and both of them are working at the best to get the best for the patient. And that is the actual goal. And that goes back again, of course, to systems. So traditionally, we talk about change, and you have some effort that you put in, and depending on what the value is, and you have your sort of attritional approach. And this is disruptive change. And this is, we've changed the way we do things, or we do something a little bit different. And what simulation could potentially do is use as a lever to exponentially get that journey going and really getting people to buy into that process. And by doing simulation-based teaching, assessment, research, and systems, you can potentially make a transformational change. So, what are these changes? Well, anyone who's worked over the past couple of years and had to deal with anything to deal with COVID, that tested a lot of our systems, and we had to look at how do you put things through the hospital, how do you manage COVID patients within a system, and that definitely is transformational change. But let's say you have an aortic dissection, and they ask you, the cardiothoracic service, to come up with a learning package for the emergency department. That's not really all that helpful in the long run. But if you take careful review and standardize patient discharge from different wards, yeah, that definitely could be something that would be a transformational change. A SIM center is asked to provide respiratory therapists on what to do when you have a failed airway. That's not really transformational. That's just sort of basic education. However, if you look at patient flow characteristics of trauma from entry for recovery, that can be screen-based or simulated, redesigned, implemented, optimized, realistic simulation. Yeah, of course, that would certainly be an example of transformational change. So with my final thoughts, I'd like to leave you with this idea about leveraging for the highest value care. And value is, you should consider in everything you do. This is sort of the driving force. And you really have to define what that means to your organization, and outcome, safety, and service versus effort or cost. And cost isn't just money, it's people's time and effort. And so what is value? And again, this is going to have to be defined by your system, what it is that you want. And these can be outcome, it can be cost, it can be safety, it can be service or patient satisfaction. But and this list is not exhaustive, mind you, but it could be, something that you have to figure out within your system and what you're going to go for. And that will depend on the system that you practice in. Just to end up, I'd like to finish up by just saying that a system of culture, safety culture, is an open and just, non-punitive system and process that encourage transparency and accountability of organizations. And I think if there's one thing that you take away from this, think about a systems tour, an appreciative inquiry approach. Thank you for your time. You're muted.
Thank you very much, Brad, for this great talk. I want to remind the assistants that you are on the other side of the globe, more than 10 hours from us. Thank you very much for this commitment. First, I want to ask the assistants to write questions in the QA. You have the question and responses, and also in the chat. Vous pouvez aussi poser vos questions en français, on va traduire. We are a little bit late. I will start with my one question. You showed us an advocacy about how to build the system and the regulators inside the circles. But many of us are from low resources countries. So what are your advices to the simulation educators how to build centers, systems about patient safety, quality, through simulation, without enough budget, without enough human resources? What do you think?
Yep. No, I think, like I said, no one's got any money these days. New Zealand is sort of a wealthy country, but not entirely. And the way that I've chosen to do it with my simulation center, and what sort of worked in other places in New Zealand, is start with low-hanging fruit, easy things, and sort of prove your value. And it's hard to ask for money. But it is not necessarily hard to ask for resources. So no one likes to be asked for money. But if you say, well, I've got this program and I think that we're going to save money and create a more patient safety, and if you just start with small things, whether it's, we use the simulation program to look at discharge advices using the talkback method. Yeah. To reduce return visits. And we reduced return visits by 10%. And then we got a little bit more, and essentially looking at low-hanging fruit, I think, is a reasonable place to start. But yeah, that's a tough one. And look, I think you just got to be creative and recognize that things do cost money. But again, it's what the organization values. And if they know what they value, that's what you go for.
Yeah. And do we need absolutely mannequins, new technologies for this issue?
No, definitely not. Definitely not. You don't need to spend a lot of money for most of this stuff.
Yeah. Okay, thank you. We are a little bit late. I don't have question for the moment. If we have questions, I will ask you later after the next speaker. So the next speaker is from India, Dr. Vijayanand Jamalpuri is the head of Pediatric Simulation Training and Research Society of India. He is a pediatrician and recognized neonatologist. He will talk about what are the key strategies to prevent medical errors. And as you know, medical errors is a very big issue since the report of the Institute of Medicine. It's a huge aspect for patient safety, and the recommendation for simulation training was built from there. So, Dr. Jamalpuri, the floor is yours.
Yeah, thank you, Dr. Adib. Sorry, I'm saying hopefully right. So good morning, good afternoon, good evening, depending upon wherever you are. First of all, I want to thank Morocco Sim for giving this opportunity, and Dr. Mohammed, the head of the Morocco Sim. I'm just sharing my slides. So I am Vijayan Jamalpuri, a neonatologist, a neonatal pediatrician from Hyderabad, India, and also president of PD Stars India. So what I want to say first is greetings from Hyderabad. That's a 400-year-old monument, historical monument, Charminar from my place. Yeah. So what I'm going to touch or cover in the next 20 odd minutes is what is medical error, how big the problem is, why do they happen, what are the different types and the strategies to prevent them. I may go along and such because I wasn't sure whether I take everything about the simulation, but I thought I will talk overview. And it's very difficult, actually not difficult, it made easy after Dr. Brad Pecker's talk. We already talked quite a few things. How do we ensure that safety where the medical errors don't happen? So he said it. Actually, my lecture may not need, but anyway, I'll try. I make an attempt. Okay. So medical error, and we all know the most frequently quoted document is "to err is human." This is a 25-year-old document from United States of America. And this made the world in general and the America in specific to talk about those uncomfortable things which are errors in healthcare. And so let's talk about it. Let's ensure that whatever we do, that for the right outcome in the right way so that we can prevent the mistakes. So you might all know, and in this, what the definition is, you can see a failure of planned action to be completed as intended, the use of a wrong plan, or the use of a wrong plan to achieve an aim. So what you are intending, you are not achieving. In fact, you may cause a harm and you may be doing entirely different than what you want. But why this happened? The most important statement they make in this document is the problem is that it is not bad people in healthcare. It is the good people are working the bad system that need to be made safer. So last 2 decades, there's a worldwide there are campaigns about patient safety, which is a very encouraging thing to happen. And yeah, so I don't need to, but I still give some statistics. I have got some US statistics. It is the third leading cause of death in US. I don't know about the developing countries. The data is a bit variable, and approximately 400,000 hospitalized patients experience some sort of preventable harm. 200,000 patient deaths from US annually due to preventable medical error, and estimated cost, you can see 20 billion each year. And it is estimated that healthcare cost can go up to 45 billion annually just due to healthcare information. These are data from US, from one of the studies, okay? And then, so 1 in 10 patients experience an adverse event in the high income countries. In the low income countries, there's a one estimation is that, and low and middle income countries is 134 million adverse events due to unsafe care and 2.6 million deaths every year, according to recent estimates. And the social cost of patient harm is 1 to 2 trillion US dollars per year. You can see how big the problem is. But I have a problem here. The problem here is this is only reported data. There is so much unreported data across the globe. Okay. So I'm sure you all agree with me that. Sorry, I'm trying to change the slide. 1 second. Yeah, okay. So I have a data from India as well. Me being from India. This is a approximately 10-year-old data. 5.2 million medical injuries happens in India. But bear in mind, as I said earlier, so it is only reported data. There's a lot of unreported data as well. So what does the medical errors do? It can kill the patient. So it increases the mortality. It increases the morbidity and eventually can cause economic burden. But not just that. It can negatively impact the patient, family, clinicians, and support staff. Healthcare professions can feel guilt, anger, inadequacy, and depression. We have seen healthcare professionals across the globe who even committed the suicide on these perceived medical error, not necessarily done medical error. I certainly did medical errors, and some of them which I have not disclosed. There's another important reason why the huge impact of medical errors, and certainly in my country, in India, unfortunately, and this is increasingly increasing, which is violence against medical healthcare professionals. So you can, I'm just posting some pictures here. And then when you look at more data, and no country is exception, it is a global phenomenon. So there's another reason, there is another significant impact of the medical errors on healthcare professionals is our life can be at risk due to not necessarily real happened event, but also perceived medical errors. I'm insisting on that. So why do these medical errors happen? So I can go by one the type of the medical errors. But what I want to say, I want to remind one of the beautiful statements when by a Professor Chandler from UK. It was said 25 years ago, approximately. And he said, medicine used to be simple, ineffective, and relatively safe. But now it is complex, effective, but potentially dangerous. You can imagine what happened in the last 25 years. How many gadgets, how many healthcare systems, how many subspecialization, how many teams are involved in one patient care. So the more complexity, more errors. We know that. Yeah. And so error happens because of lack of knowledge and skills. Yes, they do, but not always though. So not always the error happens. So the Western data says the human factors are responsible for 70%. So they do. So, and Indian data and from the low income, middle income, the data is variable and we don't know exactly how much, but across the globe, the errors are the results of amalgam of lack of knowledge, skill. To tell you, you're all simulation experts, what human factors are. They are any factor which influence our performance is. So it could be as Dr. Brad Pecker nicely already said, he said organizational and system issues, and it could be individual character of if you are a person who are not approachable, your fellow colleagues may not until the baby gets sick or the patient gets sick. So that's why anything could be a human factor. And how do we prevent these human factors? Or for that matter, any medical errors, what are the key strategies to prevent? So we need to create a safety culture. Dr. Brad Pecker did show this diagram of patient safety culture, not patient, sorry, safety culture hierarchy. So, and on one end, you have a pathological on the bottom end where the culture, the safety culture here is we don't care as long as we are not caught. On the other end, extreme end is a generative where we do business only the safety is ensured, like oil refineries, aviation industry, and nuclear power, and so on. So, but unfortunately, even in developed countries, the people can correct me if I'm wrong. I don't think it is beyond the calculate. Healthcare is not even probably at the calculative stage, and maybe fluctuating between reactive to calculate, where things go wrong, then people come in, but the system may be in place, but they don't work all the time. Okay. So, and this is the document I want to mention, the Global Patient Safety Action Plan for 2021 to 2030 and towards eliminating avoidable harm. This is a beautiful document. I confess I did not have a chance to read entirely, but I read here and there, but the vision is very appealing. A world which no one is harmed in healthcare and every patient receives safe and respectable care every time, everywhere, no matter what they are or where they are in the world. Well, the intention uh, and the vision is great, but the implementation is a problem. But they also give us a approach, a blueprint how to go about this vision. Who are the people need to involve? The governments across the globe, healthcare facilities and services, hospital, community healthcare, and stakeholders, non-profit organization, of course, the World Health Organization. And the mission is to drive forward the policies, strategies, actions based on the science and the patient experience, system design, and listening from various partnership to eliminate all sorts of avoidable risk and harm to the patient and achieve maximum possible reduction in the avoidable harm, which I would say medical error in this context due to unsafe healthcare globally. So how do we that? The pillars they mentioned, as you can see, I don't need to read. And the most important, I feel everything is important, but the one thing which often forgotten is patients and families making them as a partners, and also learning from our mistakes and creating that safety culture, and what is the evidence says so far, and policies action, not one thing, several things, and of course science needs to go to that implementation stage in the right way so that the right care received and unavoidable harm can be achieved. And so one of the ways to do is reporting your adverse events and sentinel events. And so what is adverse event? Again, I don't need to tell the definition, which is anything which cause the patient injury, resulting any prolonged hospitalization and disability, other than due to medical or surgical condition of the patient and due to the process of treating that particular patient. And so as we know, these adverse events tend to happen more if the patient stays more because their exposure to the risk is more. And no system is foolproof, okay? And the sentinel event is the one which involves the death and serious physical or psychological injury to, and the risk thereof. And so it is a serious adverse outcome. So these are the examples. I don't need to read, and I don't need to read each and by. These are the examples of sentinel events. And we can learn from these adverse events and sentinel events by root cause analysis, which you all know, those who are aware with the patient safety, and to discover the causative and contributing factor that resulted in this particular event. Identifying those factors help prevent repeated errors, or even the error starts in the beginning so that you can mitigate and turn that into an adverse event. And primarily, we need to focus on systems and procedures. Again, Dr. Brad spoke about that rather than individual actions. But when you look at the evidence, the systematic review says that yes, it identifies the why the errors happen, and unfortunately, the no strong evidence to say that it will ultimately change the outcome of the patient. That means there's a problem with learning from the mistakes and implementing the right care pathways even after learning from adverse events. Okay. And of course, one of the ways to we do in simulation is teaching the CRM. And I know a majority of you know, or maybe all of you know about CRM principle into medicine. To my knowledge, was first brought by Professor Gaba, the anesthesiologist from the US, and where you coordinate all your available resources to optimize the patient safety and outcomes, and your CRM even starts before the crisis. Even something goes wrong, you are able to identify, mitigate, and again, the Dr. Brad spoke about this. So these are the, again, I'm not going to read. Whenever we train our healthcare teams on crisis resource management with the core CRM principles, and your performance get better in real life, and which can mitigate or which can decrease the medical errors. A type of errors from the medical errors, it could be surgical, diagnostic, medication, equipment, patient falls, or hospital acquired infection, and of course communication failure. Or for all these errors, the communication itself could be a reason. So surgical errors, again, I'm giving a brief overview why they happen, as you can see. So it could be a cognitive error, it could be a clinician factor, or a miscommunication, or organizational factor. There might not be enough space to do the difficult surgery. So I'm not a surgeon, I don't know much about it. Yeah, but how do we overcome it? Checklist, you all know Atul Gawande, I need one of the key people who involved with the world's surgical checklist, and which has showing the positive results. And of course, the surgeons who are surgeons among you would know. Probably I don't need to tell you. One of the things I want to share the personal experience. The antibiotic prophylaxis to not only for deep vein thrombus prevent the surgical site infection. I deal with the very small babies, and where we have a wound infection, wound descents, and resurgeries, and we lost some of the babies as well. So what we ensure that we have a perioperative prophylaxis, not all of the surgeries, certain surgeries, and where we send the antibiotic along with the team so that they can give within 1 hour of skin to knife. And diagnostic errors, again, I think you can see the common theme following here, why these errors happen: knowledge gap, distraction, and failure to consider the diagnosis, that is those called fixation errors, this but nothing else. And also inadvocate follow-up of if anything not quite right, to follow it up and see why that wasn't right. Yeah, and diagnostic reducing the diagnostic errors, you can see. And again, the previous speaker spoke about system-based safety checklist, cognitive aids, and also algorithms to guide the decisions. And now AI is creeping to help us, and also encouraging the critical thinking. And of course, we need to speak to somebody else if you are not sure, working as a team. And you can also see one of the ways to decrease the diagnostic is the simulation-based training. And of course, interdisciplinary team on all the time taking the feedback to improve our performance. Medication errors, I needless to say, it is a big problem across the globe, and solutions are variable based on customized to where you work. And it could be a prescribing error, dispensing error, dosing error, administrating error, and overwriting the prescriptions. And sound alike, look alike medications can cause the errors. And unfortunately, not all these errors are reported. Okay. And again, I'm not going to read all these. You can see there are a variety of strategies how these can be prevented. And if you want, I can share the PPT later on. And this is our own experience when we did a traditional, usual classes of medication safety, but they were not showing to decrease the medication. So we started doing the sim sessions, simulation, improving medication safety. And you can look at the data and how nicely it has improved. Now it has become a regular in our unit, where we do a sim-based teaching activity for medication safety. And device and equipments, again, there could be a problem with the designs, mishandling, and we don't know how to use it, so we break it, and malfunctioning of this. And if you tend to use different manufacturers, is that okay? Am I?
Yes, go for it. Yes.
Yeah. Okay, fine. So, and poor maintenance and so on. So again, I'm not going to read. Oh, 1 second. Yeah. And these are the variety of strategies, of course, maintaining them. But again, I feel the institutional, organizational awareness of the healthcare professionals about the technology related difficulties is important to make them part of those policies, decision makers is also important so that they can choose what works for them rather than somebody else giving them to work with certain equipment or technology. Okay. Of course, I don't need to say how the cost of hospital acquired infection and a simple basic stuff we know the one of the most parameter which can prevent this is the basic hand hygiene. But we know that that should happen. Intentions are there, but there are a lot of barriers for implementation. And again, there are a variety of strategies. One of the things which is working for us, I can share that we also not do direct audit, we do CCTV audit. So when we looked at, there's a mismatch of a big mismatch of direct audit of hand hygiene to the CCTV, like 67, so 80% was the direct audit, and we shocked to see CCTV audit was only 30-40. Of course, we have taken a concern from the all the healthcare professionals, but we don't penalize people. We use in generic way rather than individual way. Okay, false. Thankfully, not a major problem in pediatric and neonatology where I work, but certainly a problem in the big people, and the medications can cause this, and the clinical condition of hypoglycemia and altered sensorium of the patient, and you can see, and a geriatric nature of the patient can all cause. And again, I'm not reading the list. There are variety of the strategies to prevent these falls, which is avoidable harm. Of course, my favorite one is a communication error. Okay, communications happen, errors can happen all the time across all the healthcare facilities, I strongly believe, and because of the patient behavior, but most important, the environmental distraction. And you can see the cell phones have disrupted and the families and the work across the globe. And but of course, they are also useful, but we need to be careful and conscious how we use them, and the cultural differences and hierarchy. I don't think I worked in UK and New Zealand as well. No system is hierarchy proof. Of course, it varies from where you are. And language barriers, yeah, obviously, and socio-economic. And we also need to conscious about our unconscious biases. And Joint Commission document says that more than 50, oh, sorry, more than 50% of never events had a communication failure as a major contributing problem. That's a factor. You can understand how big the problem is. So we conducted a survey. The PD Stars conducted a survey few years ago to see what are the barriers, a national survey across India. And these were the barriers. You can see one of them is lack of training, workload, approachability. And when we asked them, did they receive any structured training in communication skills? Only 1/3 said they received structured training. And of course, it's a small sample for a big country, diverse country. And then we conducted a communication skills training across India. What we do is point simulation activity, what we named as Simulathon. And we shared the material with all the healthcare professionals who are interested to join us, and ask them to conduct a simulation scenarios, especially specific to communication. And these are the 44 centers participated from 4 countries. And these are some of the pictures. And you can see there's quite a key learning things happen. But not only that the learners learned, but also all our simulathons where we did on these specific issues, they identified system changes, they identified the latent threats which can be minimized so that the errors have come down. Yeah, some of the pictures from that. So we also did on occasion of SSH simulation week, and those are some more pictures I'm just showing you. And then finally, I am going to finish when I ask the AI or the chat GPT, whatever you call, is what are the 10 ways to prevent the medical errors? You can see communication comes on the first. Enhanced communication implement checklist protocols, use technology effectively, encourage culture of safety. That needs to be ingrained in us. And that's why we are here today. And continuous education by training in which you amalgam, you incorporate your simulation. And another key thing I feel is engaging the patients, families, and empowering them to ask for safety. Yeah, not to violent with us, but ask for safety. Regular audits and feedback, standardize the procedures and documentation, improve teamwork and coordination. Of course, use of barcoding and radio frequency identification. Okay. Again, well, Dr. Vijayanand, you said so many things nicely, but these are all on the paper. How can we implement that? So I go back to the document given by the WHO. There's a nice description of how we can achieve all these, and it is freely available, and I'm sure some of you already know about this. And to achieve that every patient receives safe and respectable care every time, everywhere, anywhere in the world. And now in the last few years, increasingly our lives have changed, are going to change much more with artificial intelligence. Is it going to change? Is it going to decrease the medical errors? Well, they will do, but it may create new problems. And we know that with the other technology, we did see that. So we need to get prepared for that as well. So I'm going to play a little movie clip from one of the Indian Hindi movies and have a look, and then I'll conclude.
बस एक ही काम करना है, ये ईंटें जो है ना वहां से उठाकर यहाँ रखिए बस, ठीक है?
Language is not a barrier. You don't need to understand what they say. But anyway, you watch this.
चले नहीं जाने का है, अपना हाथ का इस्तेमाल करने का है, समझे? चलो क्विक क्विक चलो। अब एक काम करो, ये ईंटें उठाकर वापस नहीं रख दो। दादा एकदम ऐसे भरना बात करेगा या समझेगा? नहीं समझेगा तो वापस वापस एक दो, एक मिनट इसको गलत कर, यहाँ से लेके वहां तक एक लाइन में खड़े हो जाओ। समझे तुम लोग?
Right, I think
एक ही काम करना है ये।
I think the message is clear. So no matter what technology come across, no matter how much artificial intelligence is going to come in, at the end of the day, it's all about people, and not working same time is what teamwork. It is working competently, coherently for the purpose of the outcome we want. That is a patient carrier without harming them, working together. That's the reason why we are connected across the globe for the patient safety here. Thank you so much for listening. I'm happy to take any questions.
Thank you very much. Great talk. I especially love the slides. I am not the only one. Dr. Jamalpuri, you showed the WHO strategy, and we are last week, the September 17 was
Yes, patient safety week.
the World Safety Day.
Yeah.
World Day for Patient Safety, and the slogan was "Get it right, get it safe." It's about diagnostic issues.
Correct.
Yes, and as you showed, diagnostic errors are not mainly medical knowledge, but there are human factors, there are communication issues. When you build a program for simulation training, how can you do the balance in training between all these issues, between medical knowledge, communication skills, and human factors?
Yeah. Okay, excellent question, Dr. Adib. And what I refer here is refer to Boston's sim zone model. So based on who your learners and the teams are, so if you are teaching a level one, zone one learners who are as just skill training, and we don't incorporate in human factors. But if you're teaching where the teams are working together, and already those who have a reasonable knowledge and the skills in that area, the team, we incorporate more human factor. But having said that, the hierarchy which has given by the sim zones by Boston team, Dr. Peter Weinstock and team, is actually arbitrary. I would see the human factor element is there for at every level, but it increasingly increases as the more competent learners are. But having said that, the competent learner likely to do a mistake and is going to be big. So you need to incorporate. To answer the question, I would say based on what the learning needs of our teams and based on who we are involving that particular simulation exercise. I hope I answered it.
That's make me because I always say that with our colleagues. For every learning in the curve learning, we have to change to adapt the objectives and the technology also. So
Correct.
when we build a center, if we have pre-graduate students, we don't need mannequins. We have to focus on objectives, and low technology for diagnosis, for example, is to, for sure, the human factors are not the first but communication is in all the steps.
I agree.
Sure. Okay, so I'm looking if there is a question from the audience, not specific to the topic, and we are a little bit late. Thank you very much.
Thank you very much.
I want to congratulate Morocco Sim for this, and also to remind that Morocco Sim is affiliated to the New Zealand Association for Simulation Healthcare, and shortly we will build an affiliation with your PD Stars. And it's an honor
definitely.
for us to build this network and to collaborate and exchange.
Definitely.
And it's an honor for us to have you with us.
Thank you. We have a huge support from New Zealand as well, and US, and Dr. Mike Shepard is one of our mentors. And I was in New Zealand for a couple of years for my training. So thank you so much for inviting me. It's really a pleasure. And you have to excuse me because I have some clinical commitment this afternoon.
Jamal Puri,
Yeah.
I have a question from the audience, and I want to give, because it's from a third-year medical student. Our students are very important for us. So he asked about he'd like to know, how could we manage the human factors like their feelings, pain, anger, and others BCU we can't they can't have in their courses.
So how can you incorporate emotions, which is the part of the human factors? Is that right, if I understood correctly?
Yeah.
Yeah, okay. So again, see, depends. You incorporate into your simulation scenario, but bear in mind, you should not overdo. And emotions are subjective feelings. You need to be a bit conscious about that. And when the very nature of somebody agreed to participate in simulation exercise itself, they're agreed to learn. So you should balance those emotion-based human factors very carefully, I would say. You should not overplay. What we have seen is sometimes the standardized participant overdoing the stuff, which actually can intimidate the learners. So, but again, I congratulate that medical student asking for that question. Humans are full of emotions. We can't shy away those things. And we need to be conscious to learn about those things. And I'm sure the future generations will learn more about that.
Thank you. Great conclusion. Thank you very much. So I give the floor to our moderator, Mohamed Driouch. Thank you very much. It was a pleasure and honor to be here.
Thank you very much.
The floor is yours, Sir Mohammed.
Thank you very much, Dr. Peckler. I saw that the game finished, so congrats to the All Blacks for the big win. Thank you very much, Dr. Vienard. Best of luck to the captain Rohit and his company for the next cricket game again in Bangladesh too. Thanks to Professor Eddie for experiently managing the session. And thank you all for your insightful presentations. There is always so much to learn in this field. Before leaving you for a short break, we're gonna be back for around 10:25. I would like to also thank our main sponsor for this event, Moroccan healthcare supplier, MHS.
Hi, my name's Anna. I'm going to be your nurse today.
Hi, Anna.
Can you give me your name?
Yeah, it's how.
How can you please move your head to the right? Can you please move your head to the left? my name's Anna.
And now, without further ado, let's move into the second session titled Designing and Implementing Simulation Training. I'm thrilled to introduce our second session chair, Dr. Shairi Ahlam. In addition to being one of the best and the leading anesthesiologists and intensivists in the kingdom, Dr. Shairi is a prominent figure in the African healthcare simulation community. Her groundbreaking work focuses on integrating simulation-based training into medical education, with a strong emphasis on curriculum development. Dr. Shairi, the floor is yours.
Good morning. Thank you, Dr. Derwish, for this kind introduction, and a huge thanks to the Moroccan Society of Simulation in Healthcare for the organization of this remarkable international conference. I would like to thank also Professor Mohawi for your tireless work and your dedication. They are deeply appreciated by the simulation community. So, good morning, everyone. Thank you for joining us from around the corner or across the globe. It is my honor to facilitate the second session called the Design and Implementation of Simulation Training. So, during the next hour and a half, we will focus on this eminently relevant topic, given the recent trends in education, healthcare, and patient safety. So we'll be diving into key insights, best practices, and future trends that are shaping the field of simulation training. We are privileged to have an outstanding lineup of speakers for this session. We'll have Professor Aziza Ben Talha from Morocco, then Dr. Jeffrey Marvin Jansen from South Africa, and third, Dr. Ibrahim Al-Balawi from Saudi Arabia. I'll be introducing them gradually before their interventions. That will last approximately 20 minutes, and we'll leave 5 to 10 minutes for the questions. You can send already your questions on the Zoom chat, and we'll be addressing them progressively. So first, we're going to listen to Professor Aziza Ben Talha. Professor Ben Talha is a prominent figure in pediatric anesthesiology and intensive care here in Morocco. She's also passionate about training in healthcare, and especially in the topic of patient safety. She will tell us when simulation should and should not be in the curriculum. Professor Ben Talha, the stage is yours.
Thank you, Dr. Ahlam, for your kind introduction. Extremely pleased to be there and to, I don't know if my presentation kind of had been, do you see my presentation, please? Hello? Hello, hello. Do you see my presentation, Ahlam?
Already not?
No.
Do we have it?
Not yet.
Okay.
Not yet. Okay.
Okay, let's try again. Here is it.
Aziza, good morning.
Wait.
Aziza?
Good morning, yes, Professor Marai, good morning. Oui, yes,
okay.
yeah.
Everything is okay, no problem. So,
Okay,
could you...
no, you see my presentation? Not yet, right?
Not yet.
Let me see, I just share it. It is working?
Yeah, it's work for me. It's okay.
Great.
Put it in mode diaporama and go ahead.
Yes, let's go. Okay. Okay, thank you so much again, Dr. Ahlam, for continued that introduction. I'm deeply honored to join an outstanding speakers here for this international e-conference on training and simulation for patient safety, especially for those two occasions that are the World Patient Safety Day. And when we're talking about safety, we're talking about simulation. And for this 10th anniversary of the Morocco Sim, and I want to congratulate Professor Mohawi and all the team for what they are doing for simulation, and especially for Morocco simulation. Okay, so I have to talk about or to answer to when simulation should or should not be in the curriculum. And it can be just, something that can be seems easy, but in fact, it's a tricky question. So let me try to answer first as it comes. And if I ask you when simulation should be, you will probably say like in the picture everywhere, all the time. But you will see that it's not that easy. And as me, you are probably a medical simulation lover, and that means that you want to use it everywhere, and you don't want to develop where we shouldn't use simulation. But it's something that is understandable, but you'll see that we have some rules to respect. Okay, but before beginning, I want you to answer some question, if I may, so I can know if, like me, you are a medical simulation lover and you want to use simulation everywhere. So please, if you can scan the QR code that is there, please scan your QR code. And for those who doesn't have how to scan the QR code, you can join at slido.com and go for inserting the number that is below. Or maybe for those who doesn't want to do that, please, you can answer via the chat. So please try to do it. What do you think we can use simulation for? Do you think that we can use simulation for enhancing knowledge? If it's a yes, please tick the question. Thank you. Thank you so much. Do you think that we can use simulation for enhancing knowledge, soft skills, improving technical skills, evaluation? What do you think about it? Assessment, research? Okay, I have some answers. Thank you so much. Okay, let's go. Research. Do you think that we can use simulation for research? Okay, I have some answers. So we can use it maybe for, yes, thank you, for soft skills, for technical skills, of course, for research, for knowledge, for evaluation. Go for the other ones. Can we use simulation for decreasing medical errors? I think that we had a great conference about that. Yes, of course, it was good. It was a good conference, okay, a good lecture. Organization, being ethical, of course, never the first time on the patient, and we are here for the patient day safety, so for increasing the patient safety. Thank you for your answers, and they were all right. There was no wrong answers. Of course, if you answered yes for all those questions, it is because you are a simulation lover like me. And if you are a simulation lover, you will be happy to use simulation everywhere. And you are right, because this is evidence-based medicine, and you see it here in this paper, who is talking about nursing education for their undergraduate people. And this is something that works for knowledge acquisition, self-confidence, skill performance, and we can use it for everything that we already cite. And this is for undergraduates, but also there is this Italian paper that is talking as early as possible for, of course, undergraduates, but also for the graduates and postgraduates and for the continuous education. And it's also work for the training and for the assessment. So yes, you're right. We have to use it everywhere, and we have to use it as early as possible. And this was the answer of Dr. Haj Mohammed Abbad, who is Canadian, and who is using simulation in his center of expertise as soon as possible, and from the first medical school year. And he said that simulation offers more standardized learning. So this is probably our answer for all of us. You know, we have to use simulation as soon as possible, but there is others that will say that, you know, simulation, okay, but it's just a bridging. This is something, just a bridge for bridging the gap between the classroom and clinical practice. And so if we have to use it somewhere, it will be just before the clinical practice. And they're right, but if we take in account the increasing number of students, the decreasing number of instructors and their availability, the standardized learning, the ethical and legal rights, and the high insurance cost of the internship, probably that's here, simulation is the best that we can do with. Okay, if I want to stop there, I can. You know, simulation must be used because it's evidence-based medicine. We have to use it as soon as possible. And how we're going to integrate it, we will have the next speaker to talk about. And so it is just a lot of advantages, but it's not that easy. Why? Because like me, if you are a simulation lover and if you discover simulation, you will try to use it everywhere. And you will be like the mad scientist. And this is me, a mad scientist who used simulation with in systematic manner, separate from the broader curriculum, with a lack of expertise, with overusing it, without clear learning objective, with limited resources. I didn't care about space, equipment, time, administration, if everyone was okay or not. And it was really time consuming, but I really wanted to do it. And I thought I was doing it right, but I could be harmful without knowing even that I was harmful. So let me through my story, share with you what is simulation, what is curriculum, and when simulation should or should not be in the curriculum. And here is me in my first year of medical school, and you can probably, for most of us, we had those kinds of boring lecture at the university where we probably followed only the half that was in it, and we were bored, and we tried as hard as possible making our eyes open, but it was difficult until after some days we discovered the anatomy lab with the possibility to touch bones, to do dissections with cadavers, and to begin doing clinical cases. And some year after, I will discover that it was normal because the average retention rates for lectures just 5%, you know, and this is a passive teaching methods comparing to active ones when we can have better average retention rates. So I had, 10 years to wait to discover what was simulation. And it was with Operation Smile, which is a global alliance that tried to fix facial deformities, left cleft palates. And for working with them, you have to validate the basic life support and the pediatric advanced life support and the advanced adult life support. And for doing that, they did it with simulation. And this is my first discovery of simulation. And I was like, super happy and like the kind of the mad scientist that I talked before, and try to use simulation everywhere with my learners, with my students, with my interns, with my residents, with at home, everywhere. I was really happy to discover it, but I didn't know that I did it on the wrong way and it could be harmful for my patient because I was learning something wrong to my learners. Until I discovered the university diploma with Professor Mohawi, Professor Hassan, and all the team. And at that time, I understood that simulation is just a pedagogical strategy, among others, that try to resemble to the reality and try to develop knowledge, skills, and attitudes. But we didn't have to use it in the bad way. We have to respect the briefing, the scenario, the debriefing, and the debriefing we have to make it right, not to break it, and that we could use it for training, research, and that there is a lot of modalities that could go from mannequins. There wasn't just mannequins. I thought it was just with mannequins, and I discovered that we could do big things without any mannequins, of course, with human modalities or the VR or the augmented reality, the hybrid, of course. And I discovered also that we have to choose, as it has been already discussed, that we can choose our modality depending on the pyramid of Miller, independent of our objective. If we want just to improve the knowledge, or that we want to go to skills and to attitude and to be as real as possible and to increase the level of simulation fidelity and the realism and the complexity. And so at that time, I began to do it, I think, in the right way, until I found my residence here. Here is a real residence that was not happy, but I was a little bit annoyed about what I was saying. And so I asked him, "What's wrong?" He said, "Sorry, but I'm not interested on what you are doing. And can I know why? I'm not mad at you. I just want to understand." And he said to me, "We have, this cardiovascular system to exam with Professor Bensouda tomorrow. And actually you are talking about respiratory distress. And so I'm not interested. And here is our program and we have to talk about cardiovascular, actually not respiratory." And I said, "Oh my God, he's right." And I wasn't supposed just to come today to talk about respiratory distress or something else. And they have the exam about cardiovascular one. And I remember this slide that have been done with Professor Hassan Adib, who explained as that simulation should be integrated into an existing training curricula, and that we are here the simulator inside with the instructor and learner, and then we have a content that is going to depend on learning objective, and the learning objective are depending on the curriculum, and the curriculum is depending on the institutional needs. Okay, this is so complicated for me. I tried to understand. So what is a curriculum? The curriculum, it's not the program. It's, an educational proposal that is going to develop all the teaching methods that we're going to need, and the learning outcomes and the assessments, the procedure, and of course, the assessment of that procedure proving that the aim have been achieved. Okay, how we can do that? This is something that already exists. Yes, and I'm super proud to show you this, the Moroccan Board of Anesthesiology and Critical Care. I'm an anesthesiologist, and of course, I'm talking about intensive care and anesthesiology. And this is the Moroccan Board of Anesthesiology and Critical Care that give us our core competencies with an institutional assessments of needs. And how they did that? First, they try to do what we call the gap analysis and the training competency analysis, or the learner survey, to create the curriculum. And after, they identify the learning objectives, the needs and the goals, for writing them in the term of knowledge, skills, and attitude, and SMART, and we'll explain it in 1 minute. So how to do the gap analysis? It's easy. We just see the actual performance and the desired performance and try to see what is wrong, what is the performance gap that we want to fill. And the second is the training competencies. And this is a work that have been done in Rabat from Dr. Himmer, who tried to see the performance of anesthesia and critical care residency and tried just to ask what is going okay, what is not. And he found, for example, here that we had scientific research that was low and scientific knowledge that was unstable. So we have here our gap analysis or our training competencies. And so we have some gap to fill and with our learning objectives, and we're going to write those learning objectives in terms of knowledge, skills, and attitude. You all know how to do that. Or in terms of SMART, that's our objectives must be specific, measurable, attainable, relevant, and time-based. Okay, so if you want to make that clearer, simulation should be in the curriculum, okay, but we have first to identify the problem and the need with an institutional evaluation. And so after, we can have the question, is the simulation the best instructional medium for doing that? It is valid, it is reliable, it is utile, of course. Okay, we have a problem. Maybe the simulation is not the best to do it, not the cost effectively here. So I had the pleasure to meet Dr. Lansetnik at the ASHTIC, and we have the pleasure to have him today with us. And he's a wise man. So when I asked, how am I supposed to deal with that? He said, use the simplest technique that will require the least amount of effort to achieve your goal. Okay, and I said, okay, but simulation, it's something that we need time. It's time consuming. We need money for that. It's maybe not the best one. And he said, yes, there is techniques. And one of those techniques is instructional design model for simulation-based education for Canara, who is trying to explain it that way. You have the first cube when there is all the instructional medium that are the textbooks, the lecture, the computer-based e-learning, the television, and the simulation. And you can't go to the second cube if you didn't first choose one. And if you choose simulation, this is the time that you're going to simulation modality that we just described below, the computer-based simulation with simulated patient, simulated clinical immersion, the procedure. And after that, you will choose the instructional methods. What does it mean? We always have been, we always used to have a teacher for doing what we were supposed to do, an instructor-based learning. But actually, there is also the self-instruction with the self-directed learning, and this is the instructional method. And at the end, of course, we'll choose the presentation of what we want to do with the feedback, the fidelity, the type of simulator, the scenario, and the team composition. Okay, but there is a question, how I can go from the level 1 to level 2? I have many instructional medium, textbooks, lectures, computer, television, etc. And I have simulation. When am I going to choose simulation? And this is the best part, I think. This is what we call the zone of simulation metrics. So please concentrate with me. Okay, we have here two important characteristics, which are the acuity and the opportunity. The acuity means, we're going to see it here, is the potential severity of an event and its impact on patients, family members, and our healthcare professional. Let me explain. When I say something has a big acuity or high level of acuity, like, for example, cardiac arrest, if something happened, if someone has a cardiac arrest, it will have a severity for the patient, but also for the family, for the healthcare professional and all. And the second characteristic is the opportunity. And the opportunity is the frequency of an event. Means if it's something that is happening every day, in a learner, for a learner, he's going to face it in his training or no. For example, the opportunity to face a cardiac arrest, for example, in perioperative room is really low. There is no opportunity that he can see it. This is the best part to talk about simulation when you have a high opportunity and a low high acuity, and a low opportunity. For example, in the cardiac arrest, it's high acuity. There's consequences if we don't know how to deal with. And this is a low opportunity. Maybe a trainee that is not going to face it on his training. So it is important to do, and this is the best zone for simulation, for example, for a cardiac arrest. At the opposite, when you see the quadrant with LAHO, what is low acuity, high opportunity. Low acuity means, of course, it is something that there is no consequences if you don't do it, or low consequences. And high opportunity means that you're going to face it in your training. So of course, for that one, you don't need to do any simulation for. And this is, for example, for routine patient assessment that we do every day. He's going to see what is it, and there is no consequences on the patient. And we have the HAHO and the LALO, HAHO with the high acuity, high opportunity. For example, ventilation, dealing with a trauma, advanced life support, or airway management. A trainee is going to face that. He's going to see the airway management, of course. So it's a high opportunity, but it's a high acuity. If he does it the wrong way, it's going to be a disaster. So this is maybe something where we can use simulation. And last, the LALO with low acuity and low opportunity. You can easily see that, it's a low acuity, there is no problem, but the problem is the low opportunity. So maybe he won't see that in his whole life. So he must probably know it. It's like, for example, a minor complication of a rare disease. I hope that you get it. And if it's the case, please give me an example of HALO, that means high acuity and low opportunity, via the chat, and we can discuss it maybe at the end. Okay, so when simulation should be in the curriculum? Okay, first, simulation should be integrated into an existing training curricula. So we don't have just to begin simulation like that. We have to check if there is existing curricula and insert simulation inside it. And of course, it should be as soon as possible, from the first year of medical school, from the first year for nursing or wherever. We should choose the zone of simulation metrics, and the best zone for simulation is the high acuity, low opportunity. And last, it must be, the less expensive or cost effective. We can talk about prices, but you see the mannequins that can be really costly. But of course, we can, as it has been already said, we can do simulation without any of all that. Even it's really interesting, and I really want to try it. Okay, so when simulation should not be in the curriculum. Of course, it should not be when there is no expertise, because we can harm people with that. We have well-trained instructor in the teaching, but also in the simulation. We will have to have well-trained technician. We're not supposed to use simulation to overuse it with no clear objective. And we have to think about resources and how to convince the staff members to use it. And of course, a big problem with simulation is the lack of time. It is something that is taking a lot of time. So if you don't have enough time for doing it, it will be a problem. And so you have not to be alone doing it. So to see it in a schema more clear, we have first to identify the problem, to have the needs, and after to choose if the simulation is the best instructional medium, to see if it's valid, reliable, util, and after that to choose the modality with the goals and objective, the instructional methods, if it's a self-directed learning or instructor-based learning. And of course, we have to think about the support resources. This is something that we have to program before, the time, the duration. And of course, we don't have to do everything, every step without a feedback, evaluation, and assessment to see again the gap analysis with what we have choose and complete it and fill it. So simulation should be in the curriculum, but it must be well planned, targeted with learning objectives, enough time to introduce it and apply it in the medical curriculum with a good coordination between scientific and administrative support and with well-trained instructor in simulation and in teaching. So if I have to put that in a nutshell, simulation is a learning tool that should be integrated in a curriculum. The curriculum is, of course, an educational proposal, but it's not a program because we have to have the process, the teaching method, and the assessment of the outcomes. We're doing all that because it's evidence-based medicine, and we have to do it as soon as possible using the conceptual framework of Takayanara and using the zone of simulation metrics. And for the part how to integrate it inside the curriculum, we have the pleasure to have the Dr. Jensen, who is going to give us good ideas about that. So thank you for your attention. Hope I've done it and I wasn't boring as all lectures. Have a nice day.
Thank you very much, Professor Bentalha, for this very insightful presentation. You can send your questions and remarks on the chat, directly on the Zoom chat. Professor Bentalha asked for some examples for a HALO, high equity, low opportunity situation. And Dr. Ammar proposed an earthquake, which is
An earthquake.
luckily.
Oh, this is the best example that I could find. Thank you so much. Thank you so much. It's perfect. Yes, this is a really high equity. Of course, you can understand that. And of course, earthquake, thanks to God, it isn't something that we face every day. Yes, it is a really good example. Thank you so much. I'm happy that it has been clear enough.
Thank you. Do we have another question? I have a question about, you talked about the necessity of having or elaborating a curriculum, right?
Yeah.
Otherwise, we're going to do a simulation with very good intention, but very bad results, probably.
Exactly. Yeah.
And you told us that there is a Moroccan curriculum for the residents in anesthesiology, intensive care, which is really good to know. And does this curriculum integrate to all the technical objectives? Does it integrate some non-technical skills also to the residency? And how does simulation address these non-technical skills for our residents?
Okay, thank you so much, Dr. Ahmed, for your question. That is a good one. Yes, I'm really proud to see that the work has been done, because I wasn't aware of that our Moroccan Board of Anesthesiology and Critical Care tried to do an institutional assessment of our needs and try to develop a core competencies. Actually, there is still some work to be done, and that's for being more clear about the the objectives and how we're going to do it and which teaching methods are we going to use. I think it's on progress, and of course there is technical skills, but also non-technical skills, of course, and there is skills, but also how to develop attitudes in that core competencies. And I think it's a job that is in progress. Yes, of course, there is technical and non-technical skills.
Thank you very much, Professor Bentalha. We're going to welcome our next speaker, Dr. Jeffrey Marvin Jensen from South Africa. Hello, Dr. Jensen. I'll introduce him briefly. He is the director of the Clinical Skills Center at the Faculty of Health Sciences of the University of Cape Town in South Africa, and also the director of the African Simulation Network. He's an inspiration to many of us, and he will share his thoughts on how we can integrate simulation-based training into clinical education programs. Dr. Jensen.
Hi, good day. Thank you for the opportunity. It's really an honor for me to share some insights with you this morning or this afternoon, wherever you might find yourself. thank you to Prof. Maui for giving me the opportunity also. It's really been so amazing to just network with you, with the Morocco Sim and African Simulation Network. And it's really, like I said, really an honor and a privilege for me to be here today. I'm just going to share my screen. Okay, are you able to see that?
Yes.
Thank you.
Yes, we are able to see your slides.
Thank you very much. So, brief introduction, and thank you to the previous speaker. She's really laid a good foundation for me, and it's made my job a lot easier. So, I'm going to try and go through this presentation quite quickly, and I welcome any questions. So, I'm the head of the UST Clinical Skills Center at the University of Cape Town, and I'm also one of the founders and leaders of the African Simulation Network. But I mean, it's really a network that is the strength lies in the members. So I'm but the director, but the strength is really in everyone who is a part of that initiative. So the University of Cape Town is quite a big organization, and the mandate for me as director of the Clinical Skills Center is quite huge. So within Faculty of Health Sciences, we have over 2,000 undergraduate students and over 2,500 postgraduate students, and various postdoctoral fellows from all over South Africa and the world. So it's quite a tricky challenge to ensure that simulation is central to all of these programs. And today, I just want to share some of the insights that we've gained and some of the strategies that we've used by giving some practical examples, but then also using some of the theories that is available for integrating any simulation within existing programs. So what is integration? I think that's a good starting point. So Ronald Harden, who's really one of the leaders in terms of curriculum integration and integration, defines it as the organization of teaching method to interrelate or unify subjects frequently taught in separate academic courses or departments. So it's something that's become quite a buzzword recently. And that is supported by the literature. And if we have to look at the literature, we will see that curriculum integration, has really become quite a buzzword. And there's been lots of interest, and that is reflected in the papers that are being published around this subject. So it's something that many schools, programs are struggling with. So if it is something, and I guess that is why it's one of the topics that we're speaking about today, because it is a challenge. It's definitely not something that is easy to accomplish. So again, I'm going to give some of our practical examples, but we definitely haven't arrived. There's lots of room for improvement, and we're learning every day. And I'm looking forward to learning from some of your examples. Okay, so why is it important? So the literature is quite clear to say that if you're offering an isolated simulation encounters that are not carefully integrated into existing curricula, that is going to be ineffective and inefficient for both the educators and the learners. This is even more problematic within the African continent or the developing world continent, where there's really lots of pressure on resources, whether that resources is financial, whether that resources is in terms of manpower, in terms of equipment, etc. So we don't have the luxury to be wasting our resources or to be using it inefficiently. This is the one practical insight that I want to present to the conference attendees today, is that I truly believe that for simulation to be integrated into the clinical platform, into existing curriculum, the simulation leads, the simulation champions, if you want to call them that, have to be part of the curriculum development team. It's extremely difficult for simulation to thrive, simulation curriculum to thrive, if it's seen as ad hoc. So something that's running alongside the existing curriculum. That's always going to be problematic because as things inevitably becomes challenging and there's pressure on the curriculum, if it's seen as ad hoc, it's going to be the first thing that's going to be pushed aside and going to be removed. So definitely one of my takeaways is that for curriculum to be sustainable and successful, simulation curriculum to be successful, you need to be part of that curriculum development team. So how do we do? The previous speaker did a great job of laying the foundation for this. One of the more well-known frameworks is the Kern's curriculum development framework. And that presents a series of steps that starts with a problem identification and general needs assessment. Then it moves on to a targeted needs assessment, goals and specific objectives, educational strategies, and of course here is where simulation is the simulation leads definitely have to voice and bring their contributions to the tables to say that yes, you have been doing stuff in a traditional way. Here we present simulation as a modality that we can do things not as an add-on, but not as an add-on or increasing the workload, but as a modality that's going to do things differently. So in summary, I want to say for this is that we have to be part of the curriculum development team if we want to be integrated into the clinical platform, etc. One of the leaders within this integration, as I mentioned earlier, is Ronald Harden, and he presents the integration ladder, which is a diagram that presents the levels of integration, where one being the worst, which is isolation, where essentially the course, whatever it might be, is taught in isolation. And the end and the holy grail being transdisciplinary, where this is the highest level of integration, where traditional disciplinary boundaries don't exist essentially, and the curriculum is designed around complex real-world problems, allowing learners to develop skills across multiple areas simultaneously. So again, you can see that if we listen to the words that are being used, real-world problems, it lends itself to simulation. Is it easy to do this? Definitely not. And there are different modalities within simulation that we can use, and we've tried many of them, and it might be beneficial to your organization. So Harden also speaks around horizontal integration, but that in itself is not enough. So how horizontal integration is where it's integration across disciplines within a period of time. But then he also speaks about vertical integration, and that speaks around integration across time. So it cannot just be one domain that we're looking at. Is that, yes, it's important that we have diverse teams within our curriculum development team that are representing all of the various stakeholders that is necessary. So that would include, for example, people such as of course, we have the course conveners and the content experts. That will definitely include the student body, because oftentimes they are left out when we are thinking about how we're going to develop curriculum integrated into the clinical platform, etc. But then also to integrate it across time. So it cannot just be a one-time event, because we are aware of skill decay that happens. And oftentimes that is a trap that we fall into when simulation activities are offered, because it's oftentimes so time-intensive and resource-intensive. There is a tendency to have it as a one-time event, where we have found is to have more frequent, even though the learning objectives that we address during those events are much more contained, we found it more beneficial to have it more frequently and have it less complex. And I think that the previous speaker also alluded to that. I also want to present some work from my PhD. So during my PhD, I looked at what is the role of simulation curriculum in developing world context. because we know that the role, as the previous speaker mentioned, is that it can do many things, and us being simulation lovers want to use it everywhere. But as I said, there are pressures on our systems within developing world contexts, and we have to be quite strategic when we are using simulation within our context. And as you could see, theme number 4 exactly speaks around this. That emerged from this PhD when I interviewed experts within our context, simulation experts, and that was around simulation is ideal for clinical platform integration. We know that our learners are often struggling at various transition points within the educational journey. And one of those is when they are transitioning from the traditional lecture-based spaces to the clinical platform. And simulation has been is being highlighted within our context to say that here it has a great potential to have great benefit. The other areas in terms of the role is, as we are well aware, that it's great in providing feedback to our learners and giving them constructive feedback around the educational journey, and then also around interprofessional education. We are aware as simulation lovers that that simulation has great benefit for integrating or addressing the interprofessional education competencies that is so important. So definitely, in terms of a role, this is literature and first-hand experience from my PhD. This is that clinical platform integration and simulation is definitely a modality that we can use to improve the clinical platform integration of our learners. But I quickly just want to speak around some of the other themes that emerged from this process. The experts within this cohort felt that simulation has a great potential or great role to play in terms of forming these real foundational competencies in our learners. We know that every discipline has these core foundational concepts that are important, particularly if they are skill-based, and simulation has a great role to play in acquiring those competencies. Also, secondly, it was quite interesting is that I termed it contextually standardized competence. So on the one end, we know that it's important that our educational outcomes needs to be contextually relevant. But particularly within our setting, South Africa, it's a very diverse setting. So what happens on the one side of South Africa could be very different to what happens on the other side of South Africa. So yes, it can be contextually relevant to our geographic space, but it also needs to be standardized within those geographic spaces. And simulation is actually quite, has an important role to play in that. And then the other one we are well aware of is that simulation has a great role to play in terms of teamwork. Quickly, just want to speak around the limits and possibilities that emerged. Number one, human resource constraints. We know that just because we have a cohort of competent content experts doesn't necessarily mean that they have the competencies associated as a simulation educator. So it's important to address those needs, and faculty development has been so powerful to us. I just want to spend some time on faculty development because I do believe that faculty development is one of the other insights that I want to share. We've used faculty development as a core instrument to integrate into the clinical platform. So what we do, we have a 2-day course, and we invite we strategically invite content experts from the various disciplines to join that course. And of course, once they've been exposed to that, the first thing is that it really just opens their minds as to what is possible with simulation. And number two, it empowers them to, when they leave there, they are more equipped to give simulation a try. So that's been such a powerful tool for us, is to use faculty development as a tool to improve sustainable integration into the clinical platform. Secondly, a threat to simulation curriculum and also integration is this idea that there's a lack of curriculum time. We've heard it all, and we know that medical curricula, in particular, across the world is full, and it's oftentimes overcredited. That's definitely the case in our curriculum at the University of Cape Town. But what I present there is that simulation should not be seen as an add-on, as I mentioned earlier, but it should be conceptualized as a different way to do things. So it's important for us and the curriculum developers to look at the existing curriculum and identify areas where we can say, oh, but this is an area where simulation might be a better way to do things. But for this to happen, we definitely need stakeholder buy-in. And we have to be very diverse in that stakeholder buy-in. It's just not only just the conveners and the curriculum designers. It also speaks about management. We know that as simulation, we often do require resources. And to have those stakeholders, important stakeholders around the table earlier rather than later. This is even more important when we think about integrating into the clinical platform, because the clinical platform is a very complex area. And if we leave out stakeholders when we are designing these curricula, it's to the detriment of that program. So have the various stakeholders from the clinical platform early on, get them on board and get their buy-in. And by doing that, we are able to ensure that our program is sustainable. Okay, and then lastly, I just quickly want to present a framework that emerged from my PhD, and I've termed it the SIM-SMART framework. So SIM is a simulation, and SMART is that if we want to implement a simulation curriculum within a developing world context, these are some of the important concepts that I believe we should be mindful of. So number one, the S stands for socially accountable. It needs to be socially accountable, and it needs to be inclusive when we are designing that, of course, and particularly, and it's so important around this conflict, and that patient safety is core to developing any curriculum, and it needs to speak to the needs of the populations that we are serving at the end of the day. We have to manage our resources. That's the M. And I spoke around the various resources that extends past only the equipment and the finances, but we need to think of resources holistically. It needs to be used appropriately, as the previous speaker so lovely showed, that there are areas where simulation is quite effective, and there's other areas where it's not as effective. So we need to use it appropriately, because we cannot be wasting resources within our context. We need to think about repetition. It cannot be a one and done event. We need to think about how are we integrating so that we have vertical and horizontal integration, and not just a single event that as soon as our participants leave, they are very excited, but a month after that, they've forgotten most of the learning objectives that were shared during that encounter. And then the T is train the trainer. We know that it's so important that faculty development is central to any simulation curriculum. And then also to think about if we want to integrate using faculty development as a tool to ensure that there's sustainable integration has been quite beneficial for us within our context. So that's my presentation around how we're going to integrate. Of course, there are many tools, and I didn't want to speak at the level of what we were doing at the within the clinical platform, but I wanted to take it a level higher and speak around the theory, etc. Because at the end of the day, it's going to be very contextual to the limits and possibilities that you have within your context. And I'm very welcome, and I welcome continued conversation around this topic. So my contact details I can make available, and we can discuss and look at possibilities, and I can share some insights around your specific context if that will be beneficial. I also just want to take this opportunity to share the survey that we're currently busy with. Many of the speakers that have spoken today are part of the survey that's happening, and it's really to see that what are the barriers to us sharing the amazing work that we are doing within simulation. So we know that within particularly within the African context, because which I'm so passionate about, there are amazing things happening at various locations. But yet we don't see people sharing what they're doing. So here we're just doing a survey on that, and then hopefully through that we're able to address some of these barriers and make it more favorable for us to share our amazing work that we're doing. So scan the code, and we'd love to hear from you. And then I also would just like to welcome anyone who wants to just join. That's not a formal joining process. It's just a community within the African Simulation Network, and we have a very engaging WhatsApp group, and I'll place the link to that in the chat. So thank you very much. I appreciate your time, and I think I made it on time. So thank you very much.
Thank you so much. Thank you so much, Dr. Jansen. Yeah, you're really on time, and thank you for this amazing presentation. Do we have some questions here on the chat? It's important to make the most of this opportunity to interact with these amazing speakers. Yes, we do. We have Adnan Jitachu, who's asking, how can we run faculty development and curriculum integration hand in hand, as faculty members are important for the success of the curriculum? Thank you for the question.
Yeah. So definitely faculty development has been such a strategic opportunity for us. I think how you can run it is number two is to reduce the barriers for our participants to access that. So that barriers is not only finances. So of course, if you can offer it as a free event, that always helps. But also offering it at a time that is conducive to our busy clinicians often to join that. So that's another strategy that we've used to really engage with our participants and see when will this be the best time for you to participate in that. And then secondly, what we've tried is that also we've tried to make our courses shorter courses and maybe have numerous courses as opposed to having longer courses. Because again, the commitment, it's sometimes very challenging to commit to a 5-day course, etc. So we've tried to make it 1-day or 2-day courses, or oftentimes maybe just a morning or an afternoon, and that has been quite beneficial for us. Yeah.
Thank you very much. We have another question by Riyad Bidzawi. Thanks a lot, doctor. I have a question. How can we evaluate the effectiveness of simulation in the development of medical student skills? In other words, how can we know if the simulation has been effective?
Yeah. Excellent question. Evaluation is always, if I put on my hat as a clinical skills director, it's something that we always struggling with. Something that's always quite important to us. Again, it will be dependent on what the skill is. Of course, we have some more overall evaluation that we can do in terms of session feedback sessions. Then we have OSCE exams that we have, etc. So these are all, it needs to be multi-layered. It cannot be a single evaluation tool that we're using, and it needs to be regular. So I think those are some of the principles that we keep in mind. Again, as I said, it's going to be contextual to what the actual skill is that we want to evaluate. And of important, again, to have your content experts on board when you're even thinking about the evaluation of those skills. Yeah.
Thank you so much, Dr. Jansen. Good luck in your beautiful journey. And we're going to move on to our third speaker. We're going to hear Dr. Ibrahim Al-Balawi from Saudi Arabia. He's an eminent respiratory therapist and a quality specialist. He's also chairman of the Saudi Society for Simulation in Healthcare, and he will share his valuable insights on literature, data, and the pathway toward best practices in military medical training. Dr. Al-Balawi, hello, good morning. The screen is yours.
السلام عليكم ورحمة الله وبركاته.
السلام عليكم.
Good morning. Good morning, everyone, and good afternoon as well. You know, I had a long trip coming back from Tampa to Saudi Arabia, so it's good afternoon in Saudi Arabia, and my biological clock is telling you good morning in Tampa time. I'm really grateful for this opportunity, and I would like to extend my heartfelt thanks to the organizer and for this wonderful opportunity to share our experience and insight. I'm truly excited about this potential and for the first collaboration between Morocco Sim and the Saudi Society for Simulation in Healthcare. And I believe that together we can advance the field of medical simulation and improve the patient safety across our regions. I look forward for fruitful discussion and innovation ideas that will emerge from this conference. And I really thank Dr. Jensel for his previous lecture, and I think that my presentation is going to be like an example or implementation for most of what he said, and we are sharing almost the same framework. So I don't know if you can see my screen or not yet. It's there? Great. Yeah, I can
Yes,
see
we
it.
do.
Yeah.
Perfect.
Great.
You can go ahead.
So at the beginning, I will just walk you through what is SIM forces. This was one of the strategies that I used to come up with having the buy-in that Dr. Jensen mentioned before. And then we'll just talk quickly about some literature and standards of best practices there with evidence-based. And finally, I'm going to talk in brief, give you a glance about the Saudi Initiative for Military Medical Simulation, SIMS, and how it's meant to be the foundation for a big project that we are working on in the military medical services right now. So what is SIM forces? Before we answer this question, let's see a quick video. It's going to take only 1 minute. Hopefully that the sound is going to be shared. I tried to do it while I'm sharing my presentation, but it didn't allow me. So let's see if you can hear it, or sorry for being excited. So talking about us, about SIM Forces, it's a simulation interest group that envisioned to advance outstanding evidence-based practices, guidelines, research, and innovation to all Saudi military healthcare providers and combat medics. And we contribute to enhance readiness, resilience, process skills, teamwork, and collaborative learning across the Saudi military medical sector by leading the expansion of military healthcare training, simulation-based research, and providing new resources and guidelines for our combat and military medical healthcare trainers and providers. We are a group from different sectors in the military, from National Guard, from military healthcare services, from health services as well. And there are some private companies like those who are affiliated faculty in AMT and and others who really helping us on providing those different training and courses that you have. So now, and from here, we think always how we can get for this best practices. And as everyone mentioned, that we should have a strong foundation. And this comes really from the literature by reviewing the evidence-based practices that is available. And I read more than 400 articles on only military medical simulation and in different places that really allowed me to think about the most important pillars here to achieve this best practices, which as we mentioned on this theme, that it's the curriculum and having an integrated curriculum that really can fit our learners and can survive and can be developed in future for certain changes and based on the practices that's going to be being at the future. Same thing, resources from human resources to facilities to different simulators, all of these, it should be also thought about it as an important pillar. And finally, the faculty development and the continuous development for their material and for the curriculums that's going to be provided and the teaching and tools for assessment and teaching. It's very important to make sure that those will be the pillars for the best practices and in the military medical healthcare simulation. And from here, we look for this in three different levels, which is three horizons, what we are doing right now in the present and the near future and in the future, where what we did at the beginning, it's reviewing all the evidence-based practices to come up, as we mentioned, on those all plans and all those curriculums that we are looking for. And in near future, we are really looking to have a standardization for those practices and not to keep everyone is doing their own by different places and different ways and different methods. Standardization is very important. That will lead us in future that we are working on that to have a governance. And this is really the mission for this specialty interest group to make sure that we achieve our goal, which is to develop and implement evaluation and accreditation system for military healthcare simulation training programs that will enhance the evaluation and accreditation as well, and to make sure that these facilities are providing the proper training and the proper timing and for the proper mission as well. So let's go through a few literature review that we have been through it. And as I told you, when I reviewed more than 400 articles, I found there is some interesting themes here that we have to think about. First of all, I'm going to just give an example of one of the randomized control trials that I found there in the literature. And unfortunately, there is a lot of such researches on the simulation, military simulation based practice for this RCTs. And the other domains that it's really was important and it's we should focus as military on it. It's the readiness and the fitness and air evacuation. And there is other studies that it's meant to be used for special uses, like when we have a humanitarian missions, or there is some joint missions with different nations that we have to work with. So this is an RCT, as we mentioned here, and it's talking about a very simple procedure, which is how to perform the tourniquet on patient, and they are measuring here the skill performance and self-confidence. I will try to go through those papers very quickly just to save the time. And here again, it showed you how it's difficult to do such randomized control trials on such research because of a lot of elements that going to cause these limitations, including the confidentiality, and some missions are very classified. It's not easy to get to some informations there, and as well that you have to keep up with the missions that it's really needed to be with different sectors in the army and on the military, because we have air forces, we have navy, we have land forces, and we have defenses as well. All of those has different type and different training needs that need to be focused on. Readiness, there is a lot of papers, and I was like this paper because it's talk about virtual reality, and I believe that VR and AR it's really has been abused recently by trying to promote that it can help in producing and helping people to shape their skills. But it's mainly, I think, it can be used as a refresher and to maintain readiness, as you know, you can use it to refresh all your skills and those things that you have been knowing before and experiencing before in a simulation or in a true training, and you just keep this to maintain readiness. There's another paper about readiness as well and how to use the critical task list. And this is sometimes by having all those core competencies that you are looking for, it's going to be making it easier for you to develop your curriculum and integrate it to a truly very important simulation-based training to train people on things that they are not doing it as daily basis and to maintain their readiness as well. Same thing for here, for this paper. It's also about the curriculum and the skills. Here, same thing for preparing doctors. In role one, where we have different roles in the battlefield. And on those roles, we have to really focus on how to empower our healthcare provider, the military personnel there, to function on a certain way, which is totally different. You know, on dealing in hostile conditions, it's not like dealing in a hospital and very steady places. It's totally different. Fitness, which is also a very important part, and I wasn't thinking before that simulation can help on this part, but no, it's really if you enhance fidelity and provide a good psychological fidelity and environmental fidelity as well, you can really control some of these measures that can help you to achieve this assessment for military fitness, where you know people can really interact and you can measure their different vital signs and you know increasing heart rate and those things that happens really on such situations. Same thing here for fitness and physical fitness. Let's move to other studies that was really interesting, that in some humanitarian missions that you are not only dealing with people who are traumatized because of you know a battlefield trauma, but there is non-battlefield trauma as well, which is like dealing with civilians there and these places and in this hostile situation where you have to have some skills about how to deal with OB/GYN, pediatrics, and different things. And I found this on the literature as well. They are talking about and how to make people ready for this and to have a simulation training that really will enhance readiness for this before they go and deploy to those places and have a good practice to deal with such situation and again in a different situation that it's not like in the civilian part. Same thing here for obstetric and OB/GYN, dealing with psychological problems as well. It's very important for those who are on those battlefield situation and for post battlefield also deployment. It's very important for military healthcare worker to focus on this as well. Air evacuation, it's a very important part that it's from this journey for the injured patient from the point of injury till he goes to Role 4 hospital. This needs really a very thorough training, and it was really covered in the literature in a very, very good way with especially two teams that they call the CCAT on the US and the CCAST in the UK. They have really used this and very well, and they have published good papers on this. This is the same thing. And having this specialty interest group and going through this literature and this understanding for training needs and the gaps and the lesson learned from big armies made us to think about having something new and to have an organized initiative to have the Saudi initiative for military medical simulation guidelines. And this was adopted by the General Directorate for the Military Medical Services. And now we are working on some of its project right now. It's ongoing and inshallah is going to finish soon within the coming years. So what is SIMS? It's an evidence-based military simulation training strategy that needs to be adopted to current and future needs to enhance readiness, resilience, process skills, teamwork, and collaborative learning across Saudi military medical service and with joint operational methods as well. Why SIMS? As simple as we mentioned, it's to increase awareness and to improve simulation application through coordinated Saudi expert efforts, not only to do the training as we saw before, haphazardly, without having no curriculum, without doing a need assessment and doing the gap analysis, and to focus on the pillars to achieve our best practices as we mentioned. Our main objective is to provide Saudi military simulation teams with evidence-based guidelines to advance the application of best practices in military simulation, operations, delivery, and assessment as well. So the first fruitful project that came out from SIMS and from SimForces, it's the two M steps, which is the Military Medical Services Training and Education Program. And this is a complete program, or we can call it a complete doctrine for all military healthcare workers that are going to be those who are currently in the Saudi military forces, royal forces, and those who are going to be enrolled later on, where we think about the main pillars here, as you can see, that having a training, military medical simulation training center, and having a apprenticeship pillar that where people from their start till their end, they know exactly where they are going, and having an academic and professional also development pillar here, it's going to help on this apprenticeship. And finally, and which this is going to be in future that we are looking for, it's to have the Agency for Research of Military Medicine and Quality and Research. This will function as the governance for all new guidelines and for all applications and standards of best practices by collecting all data from our own personnel and analyzing it and working on it to come up with the future plans and to see how we can continue on this professional development and to enhance all support for the three first pillar by having a lot of initiatives as well. So by having all of those, we can focus on training plans on our main branch, which is the field medicine, emergency medicine, diving medicine, air and aerospace medicine, medical evacuation, and the MERT and CCAS team that's going to follow. So I want to finish with this scene for this quote for Albert Einstein, that learning is experience and everything else is information. For this, we really to focus on evidence-based practice and not just to follow some theories that it's not applicable in your situation, in your people and your system, and think always about having systems that fits people, not people fitting system. And thank you so much. I hope that I'm on time.
Thank you so much, Dr. Al-Balawi. You're perfectly on time. And thank you for this amazing and insightful presentation. We have
You're welcome.
Yeah, as we can see, the military field, well, is an amazing field actually for simulation training. And what would be your advice for the civilians instructors? What can we replicate from the military field to motivate the instructors about about the necessity of integrating simulation to the curriculum?
Thank you. So this is a really good question that I have been through it while working on both sides, on civilian and military as well. What I believe, especially in our countries, our developed countries, that having the buy-in, from stakeholders, it's the most important part. So working on having a leadership strategy, I think it's the first thing you have to work on, and sitting on your high values for this training. Then this will help you really to integrate simulation to the curriculum and to avoid all the resistance that you can see in future for implementing this. I have applied this strategy on 2015, where I wrote a leadership plan, and to just put all the influencing styles for my leadership, putting all of this, and I ended up having this big project that it's a national wise, and it's with collaboration with the US Army, with the UK Army as well, and with the CENTCOM as well, for all those programs that I'm looking for. So I really encourage people not only to think about the technical part or about only the curriculum itself. Think how to manage people. I think this is the most important part in our developed countries, to have the buy-in, and then things it's going to be there. You don't have to start from scratch. Just start from where everyone just had finished, and go there and start, and you can innovate on this.
Thank you so much.
Okay.
If we don't have any more questions, well, I would like to thank our three amazing speakers for these presentations, Professor Bentalha, Dr. Jansen, Dr. Al-Balawi. It was an honor and a pleasure to moderate this session. And I would like to thank again Morocco SIM and Shine for hosting this amazing international conference. So thank you all for joining us for this session. And I'm going to hand out the microphone to Dr. Derwish for this transition. Thank you.
Thank you very much, Professor Bentalha Aziza, Dr. Jensen Marvin, and Dr. Balawi Ibrahim, for your illuminating presentations. Nothing but outstanding CVs and mentors that me and all the Morocco SIM junior community are lucky to learn from. Starting from a worldwide reference in military healthcare simulation, to an African and global simulation and astrology expert, and finishing, but last but not least, a Harvard South Africa fellowship recipient. Thanks to Dr. Shairi Ahlam for smoothly managing the session. A huge thank you to all of you for being part of this exciting event, and we will be back after a short break.
You are practicing key laparoscopic skills, such as instrument triangulation, bimanual coordination, and different dissection and resection techniques in highly realistic simulation cases. But how did you get there? Did you start from the beginning? Did you place your patient in the correct position? Did you choose the right position of the trocars so that instruments are safely inserted? With Laparos, you make sure to practice the crucial preparation steps of the procedure first. Then proceed to train surgical skills in true life simulation sequences. Laparoscopy training that improves outcomes and supports better patient care starts from the beginning.
Original virtual reality simulator for intraocular surgery training. Original instrument handpieces are inserted into the simulator's model eye. Looking through an OR microscope, trainees experience their interaction with tissue and intraocular structures simulated in real time. The pre-installed IC courseware offers training at different levels of difficulty, from basic skills training through to surgical procedures and complications management. For cataract surgery training, instruments such as forceps, viscocannula, cystotome, and phacoprobe are available. The simulator provides an OR machine interface and instrument foot pedal to control fluidics. For training of posterior segment surgery, IC is equipped with a vitreoretinal interface. The integrated biomimic functions just like a real biome in the operating room. Trainees must select appropriate OR machine parameters in order to safely and effectively complete a surgical procedure. During virtual surgery, instruments such as light probe, cannula, endolaser, and vitractor are available. At the end of each task, IC provides detailed assessment of the surgical performance. VRMNet allows trainees to access their personal training data and peer group comparisons from any mobile device. Online courses extend the practical training on the simulator. Theoretical background information is enriched with videos, images, and multiple choice tests. Educators use VRMNet to monitor their residents' training progress.
And we are back. It's session 3 o'clock. Human factors and patient safety. I am delighted to introduce this session chair, Professor Nseri Afaq, Vice President of the Moroccan Society of Anesthesiology and Intensive Care, Lead of Education Planning and Industrial Relation in the African Society for Regional Anesthesia of AFSRI. Professor Nseri is a highly regarded expert in anesthesiology and in patient safety, with an impressive track record of contribution to both academia and practice. Her dedication to innovation and excellence has earned her widespread recognition both locally and internationally. Professor Nseri, it's my pleasure to turn things over to you.
Thank you, Dr. Tarwish, for this kind introduction. I am really touched. Thank you. And good morning, everyone. It's a privilege to chair this session on training and simulation for patient safety. I'd like to begin by expressing my heartfelt thanks to Professor Mohawi and the Morocco team for inviting me. This subject is one I hold close as patient safety. Without it, the care we provided cannot be effective for our patients. We are fortunate to have the eminent expert, both international and national, with us today, ready to share their valuable knowledge. I look forward for the discussion that will follow these presentations, and I invite you to send your question on the chat. I hope we'll gain new ideas to enhancing patient care through effective training and simulation practice. First, I would like to introduce our first speaker, Professor Oriol Denis from France. I am great pleasure to introduce you. He is an estimated speakers, international expert. He is a pediatrics anesthesiologist, and he is the author of one of famous book in French for the simulation. It's about debriefing. I am really delighted to have you with us, Professor Denis, today. And the first topics, it's about how the human factors influence clinical decision making and patient safety. Thank you, Professor Denis. The stage is yours.
Thank you very much. So I will share my slides.
It's okay.
Okay.
Thank you.
So good day to everybody. My name is Denis Oriol, and I work in the pediatric emergency department. And I am the head of the simulation laboratory in the University of Poitiers. I would like to thank the organizing committee of the Morocco SIM, and especially Professor Mohawi for his invitation to talk about how do human factors influence clinical decision-making and patient safety. I have no conflict of interest to disclose on this topic. As you all know, since the publication of the report To Err is Human in 2000, human factors play a significant role in clinical decision-making and may impair patient safety. And these factors are plenty. Cognitive, emotional, physical, communication, organization, and environment aspects that can influence how healthcare professionals perform their task. We will go through some examples of clinical debriefing I performed after adverse events in our institution and some simulation debriefing. And we will talk about a major CRM principle I like because linked to decision making, and we'll try to conclude. The first example, clinical example, is dealing with a transfusion error occurring at the end of the afternoon. This 70-year-old male called Mr. Jean-Michel RXXXN was born in 1953, September 6, with a blood group of O+. He was in the recovery room after surgery for aortic aneurysm under norepinephrine drip. The unit was very busy with a shortage of nursing and the need to empty the room quickly, and JMR was requiring a blood transfusion. The red blood cell pack was delivered for Jean-Michel RXYXN, born 1953, September 6, with a blood group of O neg, and was transfused. And this was a real threat to patient safety, fortunately with no consequence for this patient, but the adverse event was reported and debriefed. What happened? It took 25 minutes between the reception of the pack and transfusion, and the nurse started verification of the pack, but was interrupted 3 times. Besides JMR, a patient was vomiting and another one was trying to stand up and get out of bed. There was a lot of noise, phone calls, and so on. And the nurse said to nurse assistants, "Leave me alone. I have to do the transfusion," trying to make an attempt to secure the action. But as you can see, there was a failure to recognize the identity error during the reception of the pack and avoidance of verification during the ultimate control to the patient. What can be improved? Create a secure space-time for verification prior to transfusion, a secure action, by asking other providers to respect this time, to take over other tasks for themselves, and to develop situational awareness for all providers. It could also be implemented by Shisa Kanko, naming pointing method for verification of blood pack. The second example, clinical example, is about C-section with a green code becoming a red code. It was a Sunday afternoon during national holiday in France, and a 37-year-old lady with a scar uterus who did not speak French or English was in delivery room with epidural anesthesia. She had a labor stagnation with full dilatation lasting for 1 hour and a half, and the decision was made for green code C-section. The midwife called obstetrician, resident anesthetist, nurse anesthetist, and OR nurse. And a few minutes later, the husband called because his wife was vomiting. The resident performed a fetal heart rate recording, showing a profound bradycardia, diagnosing a uterine rupture, and the decision was made for a red code C-section. And the resident notified the obstetrician for the change into a red code C-section. The midwife was rushing into the OR, not noticing that the husband was going with her. Anesthetist, nurse anesthetist, OR nurse were already in the OR. But nobody told them that it was now a red code. Therefore, the anesthetist re-injected the epidural anesthesia instead of performing a general anesthesia. There were no rush, a complete cleaning of site. The husband was still in the OR, and they realized afterward it was a quick C-section with the decision to birth time of only 5 minutes, but without knowing it was a red code. And this was a real threat to patient safety. The baby was born in cardiac arrest. It recovered partially and was showing some neurologically impairment, even if we cannot tell for sure it was the only cause for this state. What happened? There was a lack of situational awareness. Only the midwife, the resident, and the obstetrician knew it was a red code C-section. What can be improved in this situation? To set a timeout, a recap to inform everybody that it is no longer a green code, but a red code. And this is something to be told by midwife or obstetrician, showing that there were a lack of leadership in this situation. The first simulation scenario is showing a very strong tunnel effect. The scenario was dealing with a 5-month-old infant, a former preemie, weighing now 6.5 kilos, with a fever since this morning, with cough and difficulty breathing for 2 hours, arriving in pediatric emergency department in sitting position. Her history was made of oxygen and steroids taken for the first 6 weeks of birth for a bronchopulmonary dysplasia. She also had 2 episodes of bronchiolitis. Her mom and 3-year-old brother were asthmatic. On clinical presentation, the baby had a respiratory failure with asymmetry of birth sounds. The leader diagnosed a foreign body in mouth and extracted LIGO. He found lung asymmetry with decreased air entry and stridor on that side, confirmed by double auscultation performed by the followers. And during reassessment, the follower repeated several times, there is a stridor on the right side. The leader verbalized, surprisingly, this child has probably bronchiolitis again. Given his medical history, we are going to prepare aerosol of salbutamol. This decision was completely out of the scope of the clinical reality of a foreign body stuck in the right bronchus, and of course could lead to a major threat to patient safety. What happened? There was a confirmation bias based on the infant's past history, leading to diagnosis of a 3rd bronchiolitis and infant asthma, a tunnel effect due to an important self-confidence, 4th-year PGY, and followers not questioning him, despite correct clinical findings, leading to a lack of situational awareness. What can be improved? Aiming for a shallow gradient between leader and followers, avoiding an authoritarian or hierarchical leader, avoiding passive or admiring followers, because the solution comes from the followers. They must dare to speak, report their observation, report their mental frame, until the ultimate demand to the leader to act differently, like listen, captain, in the aviation. The second simulation example is dealing with a never recognized septic shock. The scenario was dealing with a 12-month-old child coming to the pediatric emergency department for respiratory distress and fever. The history was not significant, only 2 days of coughing and fever, and on clinical presentation, he had respiratory failure, shock, and high fever. The blood test showed metabolic acidosis with a very high lactate, 6.5, and the leader diagnosed respiratory failure, shock, and fever. And the treatment was then oxygen with high concentration mask, boluses of saline, and acetaminophen. What happened? As you can see, it was an obvious failure to recognize septic shock with respiratory onset, leading to the lack of antibiotics, epinephrine drip, and respiratory support, and so on, with a real threat to patient safety. What happened? Each part of the equation was treated separately, with a lack of recognition of the whole picture, leading to a lack of situational awareness. What can be improved in this situation? As I said, salvation comes from followers. That means reassessing the situation, verbalizing, searching for cause of respiratory failure, cause of shock that relies on experience, noting that the shock is severe and requires several boluses of fluids, may require more, relies also on experience, noting that lactate is very high, relying on knowledge and experience, and finally call for help when nobody understands. From these examples, you can see that human factors can severely impair patient safety. As Peter Weinstock put those principles, he is from Harvard Medical School and belonging to CMS. Those CRM principles, role clarity, communication, call for help, utilization of resources, and situation awareness. One of them is very important because it is central to the other, is situation awareness. Situational awareness is one of the non-technical skills that most influence team performance. In 1995, Hetzley modelized situational awareness, as you can see here. From the state of the environment, it goes into the perception of elements of the current situation, first part, and then to the understanding of the current situation, second part, and then to the anticipation of future states, third part. And then it goes to decision-making process, leading to execution of action that modify the state of the environment. The perception of elements of the current situation rely on the gathering complete information, active gathering of complete information, communication within the team and outside the team, and frequent reassessment of the situation. Understanding the current situation relies on knowledge and experience, and anticipation of future states rely on the projection for future actions. So what can alter perception of current situation? Reduced alertness, leading to automatism with activation of the system 1 of Kahneman, inattention, overconfidence, disruptive stressors, high workload, fatigue, sleep debt, routine, altered emotional state, hyperfocalization, activating system 2 of Kahneman, confirmation bias, anchoring bias, representativeness bias, tunnel effect, fixing bias with reentry, inattentional blindness, you know, the very famous gorilla from Simmons and Chabris, and lack of communication, incomplete communication, not to everybody for relevant information, non-verbal communication, non-verbalization, no recap, no timeout. And now let's see what can alter understanding of the current situation. The same as in perception for reduced alertness and hyperfocalization, plus altered mental image construction. The exploded puzzle, like for the septic shock scenario, at a glance mental shortcut. Don't judge too quickly. The primacy effect, the hindsight effect, and the recency effect, and of course, the lack of knowledge and experience with omission of part of the treatment. Finally, what can alter anticipation of future states? All the causes of reduced alertness and the lack of knowledge experience. These three last slides are saying that any altered situation awareness can lead to an impairment of decision-making process. And of course, an impairment of the execution of action and probably error due to this lack of situational awareness. But there are also specific alteration of decision-making process by internal inhibition, Milgram effect, Janis effect, bandwagon effect, spectator effect, cognitive bias like bias of convenience, and to be complete, specific inhibition also during the execution of action by external inhibition, providers, peers, supervisors, family, observers, lay people, and of course, alias. What to base my decision on if I want to have an adequate situational awareness? A complete information to have a description-based decision, a best experience to have an experience-based decision, and a gut feel to have a perception-based decision with anticipation of future actions. And this will lead to the best adequate situational awareness. Simulation can provide adequate education for learning situational awareness and decision-making, highlighting importance of teamwork. But following my presentation, other orators will talk of this. I would like to thank you for your attention. And just to tell you that Poitiers in France, we are dealing with a 10th century building and 21st century building as well, and trying to learn from our past and to look forward for the future. Thank you for your attention.
Thank you, Professor Orio, for this amazing lecture. Really, it's very, very important, and we can see in our practice the human factor can be very harm sometimes for our patient, and we can be very careful. And I think the human factor would be in our practice in the training, academic training should be for the academic training for our students, our residents. It's very, very important. If we can have the question. I check it. You heard the question. This question. Just I check the chat if we have the question for Professor. Yeah. Not yet. Yeah. Yet we have the very important presentation. We have the, but not yet the question. En French, merci docteur, c'était une magnifique présentation. J'aimerais avoir quelles sont donc les solutions pour éviter tout ce que vous avez dit. We have the question in the chat to ask for the solution to avoid this issue in our practice, this issue related to human factors.
Thank you for the question. I think it's a very important challenge for every SIM educator, because that means that human factors are so important during clinical practice that we should implement them very early in the curriculum. And for students, for residents, it should be taught during simulation, should be taught prior simulation by lectures, courses, and then even at the first part of simulation training, it should be implemented partially. And so far, it's very difficult to titrate which one of those human factors should be implemented at first, I would bet situational awareness is the best one to implement first, because it is linked to any other principle. This is my way of thinking, but I think it should be implemented very early in the curriculum of for all providers.
Yes, I totally agree with you. I totally agree. We have another question. Est-ce que vous utilisez des outils pour détecter les erreurs ou les risques hospitaliers? Did you use some tools to detect some errors or risk in hospital?
Well, I think the best tools are to report and to have a culture of error and not a culture of fault. And so this is the big change in the mentality of anybody working in an institution. And but reporting is very, very important. Reporting error is the first step for learning from this error through a process including a debriefing, a multi-professional debriefing, to understand how the error occurred. And this is the very important part of the process, because the different solution to prevent a recurrence of this error rely on the mechanism of this error.
Yes, thank you for. We have another question. It's about, en France, est-ce que vous déclarez systématiquement les erreurs détectées pour avoir des solutions en les évitant par la suite? He asked for the procedure with the errors. If in France you declare this issue and these errors to the system to can have the solution or I think the process for to avoid this error in the future. Thank you.
Well, in my institution, there is a policy to engage everybody to report errors, and for a special group to study the error and to try to contact the providers afterwards to set up a retex, a return from experience, and or a debriefing, and or a simulation, in situ simulation, to replay the scene where the error took place. So there is a challenge, because not everybody is eager to report an error. But once at a time, it's increasing. The reporting is increasing from last year to this year. It increased roughly 20%. That means we have 200 errors per week in my institution. So that's about 1,000 per month. It's 1,500 bed institution. I think it's not reflecting the number of errors, because it's just the top of the iceberg. But it's a hope for working on the errors. And so this is very important, to link simulation training to the occurrence of error. Sometimes it's hollow type of error because of high-stake situation. But as you can see, it's not always hollow type, because transfusion error, there is some environment situation that are occurring during the action that's not taken in account when you say lalo, halo, haho, and so on. So that means that you have to consider the environment where it is where the error took place. So the debriefing afterwards should take care of the situation by itself and the environment also.
Thank you, Professor Orio, for this amazing presentation and answers also. And we should implement it so early this factor human in our academic training. Thank you. Thank you.
Thank you very much.
Thank you. And good morning. And we have with us the second lecture with the Professor Willett, Tim Willett from Canada. Professor Willett, excuse me, it's a leading figure in simulation-based healthcare education in Canada. As the head of Simulation Canada, he focuses on development strategies to reduce human errors and improve patients' outcomes through innovative simulation training. The lecture would be, what strategies can we use to mitigate human errors in healthcare? Thank you, Professor Willett, and you can have the microphone.
Bonjour tout le monde, c'est vraiment un très honneur pour joindre avec vous aujourd'hui. Thank you to everyone who's taking time on Saturday to be part of this. I am joining from Ottawa, Canada, where it's 7:30 a.m. and we had a beautiful sunrise this morning. So it's a great day to be with you. And thank you to Professor Maui who invited me to be here. I'm hoping my it's prompting me to change my speaking language. There we go. I'm hoping my presentation will dovetail quite nicely with the previous one on human factors, and hopefully not be too basic for this audience. As mentioned, I'm the president and CEO of Simulation Canada. My background is medicine, but I've been working in healthcare and technology and leadership for over 20 years. Simulation Canada is the national network in Canada to support simulation. Our vision is exceptional patient care and outcomes through simulation across the country. Like a lot of national networks, a major part of what we do isn't directly offering simulation-based education to students, but rather supporting the educators who do. We are a network of 68 different member organizations. These are colleges, universities, hospitals, and other healthcare services across Canada. But we're connected to, and I would estimate there are well over 200, likely 250 different simulation programs across the country. We connect about 5,000 different individuals. These are the frontline educators and clinicians who are using simulation, as well as Canadian researchers and technologists. A large part of what we do is train people on simulation-based education and simulation-based quality and patient safety improvement. And we've certified over 500 simulationists across the country. So first, a slight comparison of two paradigms, two mindsets. We're all familiar with the education mindset, I'm sure, where we understand that human behavior is driven largely, but not completely, by our own internal understanding of the world, our own knowledge, our own attitudes, our own skills, our own experiences. And that interacts with the environment around us to lead us to how we behave in any given situation. And A goal of education is to help people learn. And by changing what they understand about the world, about nature, about clinical processes, about disease processes, we can help them change the way they react to certain stimuli in the environment, with the goal ultimately of having them perform better, right? So the underlying principle, the paradigm in education is that if people learn better, learn more, if they have a chance to practice better and practice more, then they will do better in the real setting. And indeed, that's the case. There's so many studies, especially in simulation now, showing that simulation certainly is effective for individual and team training, and that skills learned in simulation do translate into real clinical practice. Patient safety paradigm takes a slightly different approach. It acknowledges that human behavior is influenced not only by somebody's own internal knowledge and skills, but also the context of what's happening at the time when they need to make a decision. It also accepts that human beings are fallible and that errors are inevitable. This second point is perhaps the most important. Even the most well-trained, well-practiced people can occasionally make mistakes, whether that's because of something that's happening internally with themselves, because of stress, because of lack of sleep, or because of something externally, a piece of information that they don't have, or a social complication that's leading them to misunderstand the situation or make a poor decision. So the patient safety paradigm assumes that even the best trained people are going to make mistakes and that errors are inevitable. So the goal then, rather than to try to make people perfect, is to try to create a system that is resilient to these errors. In our case, that's a healthcare system. So to work on adapting that system so that even though, and the assumption is people will make mistakes, how can the system react to those mistakes? How can it absorb the potential negative outcomes of those mistakes so that the negative outcomes don't actually happen and we don't get an adverse event to a patient? So the goal here is to develop a better, more resilient system and to stop the effects of an error before harm actually occurs. Now, if we take a look at the way we might run a simulation differently, what makes a system-focused simulation, which is also often called in the literature translational simulation, what makes that different than an educational simulation? First, we can look at who the participants are. In educational simulations, we're quite used to working with individuals or groups of individuals or clinical teams rehearsing together in a simulation. And of course, we try to make the environment and the tools they work with as realistic as possible or as realistic as needed for the situation. But in a system simulation, we have to think about the environment as actually being one of the important participants in the simulation. So running the simulation typically in situ, where we're in the actual clinical space, using the actual clinical tools in that clinical environment, becomes very important because you want to be able to, if you're testing a system, if you're running a simulation to evaluate a system, you want that system itself to be replicated as accurately as possible as part of the simulation. Often in these system simulations, in fact, the simulator itself, whether we're talking about a mannequin, can be very basic because we're not trying to teach people to apply certain skills in as realistic a way as possible, right? We're trying to recreate a system process. So often the mannequin, the simulator, it almost doesn't matter how high fidelity or realistic the mannequin is. What we really care about is replicating the process and the environment. The goal of the educational simulation is to evaluate participant. And of course, in a formative simulation, we're not talking about trying to score them so much as to see how they perform and be able to offer them feedback on that performance. The target of evaluation in a system simulation, though, is the space or the process or the equipment. So we're not trying to understand and evaluate the people. We're trying to evaluate the system and the processes in which they're working. In an educational simulation, our goal is to identify and correct and improve any knowledge or skills of the participants, whether it's individuals or teams. But in a system simulation, we're trying to understand the system or systems at play. The debrief in an educational simulation explores participants' internal frame. So regardless of what method of debriefing you're using, you're trying to understand where your participants are, what their skills are, what their thinking process are, and how that translated into their behavior, and use that understanding of their internal or mental frame to help them learn and grow. The debrief of a system simulation, on the other hand, explores the influence of the system on those behaviors. So rather than asking a question like, what were you thinking when you made a certain decision? The question is, what about the situation? What about our process and the environment influenced you to make a certain decision? With the subtext being that even if a decision was poor, perhaps it's not the person's internal frame. Of course, it could be, but the approach is that even if it is something, an error on the part or a misunderstanding on the part of that person, if the error was made, what about the system allowed that error to be made? And what could change in order to reduce the chance that an error gets made again? And of course, the benefit of system simulation, just like educational, is you can make an adjustment and you can try again. You can try different approaches. You can do what-if scenarios to explore different possibilities with the goal of, over time, seeing incremental improvement. I'm going to walk through several examples now of different applications of system simulations. No, I will let you know they're all credited. I cannot take personal responsibility or credit for any of these initiatives, but there's some fantastic things happening around the world, and I wanted to highlight some of these examples. One is using simulation to test clinical spaces, and this can happen at any point during the design and build process. It's an iterative process, so often it happens very early when new clinical spaces are being planned or conceived, and it can be repeated as those designs become closer to finalized and as building progresses. So this can range anywhere from doing tabletop simulations with clinical teams while looking at the potential blueprints of a new clinical space. I've heard examples of developers going into a parking garage and putting tape on the floor of the pavement to show where the walls would be in the hallways, and having a clinical team run a simulation using the tape on the floor. I've seen examples of using even virtual reality and constructing the plan for a physical space in virtual reality and having teams work in that space virtually. I've seen mock-up designs where people will actually build using very crude construction materials a rough idea of what the clinical space would look like, and teams can practice in that and provide that feedback to the architects. So ultimately, the goal here is to optimize the space. Make sure we don't run into problems where, for instance, if a code or a crash is likely to happen in one place, you don't want the crash cart to be at the back of a closet at the other end of the hospital. You want to make sure, or the other end of the ward. You want to make sure the equipment is where you need it. You want to make sure there's enough space around for people to move the way they need to move and quickly access the equipment they need. This has become such an ingrained part of some construction and some processes. For example, in Alberta, which is one of the provinces of Canada, the Health Quality Council of Alberta worked with Alberta Health, or the simulation group at Alberta Health Services and the Human Factors group to publish this guide called Simulation-Based Mock-up Evaluation. And creating these simulations of planned clinical spaces is actually now a required part of any new development and build that they do. Another common example is crisis response. So we know there's a lot of medical situations where minutes matter, whether we're talking about recognizing sepsis early and beginning treatment, responding to a massive hemorrhage, responding to a potential MI or cerebral vascular event, and getting them into a cath lab. We know that minutes in many of these situations actually determine a measurable, have a measurable impact on the probability of a positive outcome. So there's some great examples of hospitals rehearsing their response to a crisis in order to understand what slows them down. What are the bottlenecks and the lag points? So a great example of this was from St. Michael's Hospital or Unity Health in Toronto, Ontario, where they ran simulations of a massive transfusion. So pretending somebody comes into the emergency room or is on an obstetrical floor, has a massive hemorrhage, and they need to get unmatched blood to that person and infusing as quickly as possible. So these simulations involved not only the clinical teams on those floors, but even the porters who would need to be running down to the blood bank and bringing the blood up. It involved the medical lab technology group at the blood lab to understand their process. When they get a call that unmatched blood is needed, what do they need to do to get that blood prepared as quickly as possible? And by understanding this complex process involving multiple parts of the hospital, this team was able to shave 2.5 minutes off the time it takes to get blood to a patient. 2.5 minutes may not sound much, but each minute is associated with a 12.5% increase in survival. So 2.5 minutes is actually a really important and really tangible improvement in their response. Another example is either testing or trying to improve policies or procedures in the clinical setting, where the goal here is to test the policy as it is and try to break it, as it were. Try to play what-if games. So the policy says to do X and Y and Z. Well, what if I, as a clinician, were to decide to do something else instead? What if a certain piece of equipment wasn't working that day? What if we were understaffed and there's no respiratory therapist to participate in a certain protocol? And play these games of how would that affect our implementation of this policy or this process? Now, you can take one approach, which is to try to find the weaknesses of it and where it would fail. But you could also validate what works, right? Through these games, you can also say, well, okay, we've noticed that even if things go wrong at this certain step, the process allows us to compensate for that so that an error or an adverse event won't happen. And that's really important learning as well. So you can see what's robust about that process. Doing this allows you to detect latent safety threats. Latent safety threats are problems with an environment or a process that are not obvious and that may not become obvious until something goes wrong. And the goal in a safer, more resilient system is to detect and understand where those things can go wrong, where the system can fail before it actually does fail in a real clinical experience. By understanding those weaknesses, you can then improve. You can improve them, you can address them, and create a more resilient process. So a great example of this is one group that reported on complex situations in pediatric intensive care, where they simulated a variety of different complex events in their pediatric ICU. Again, not so much to evaluate their team and the people, but rather to understand how things could potentially go wrong or how things could be prevented from going wrong. A really interesting finding of this study that they did was, so they over the course of a year ran several of these events, and when they discovered a latent safety threat or a potential problem, they would document it. And what they found after a year is that the errors and weaknesses they detected through simulation were actually more likely to be reported and more likely to be fixed than actual clinical errors because of people's reluctance to report on actual clinical errors. So this can certainly be a very powerful process. Another example is disaster preparedness. So emergencies that are rare can nonetheless happen. The goal here is to rehearse a system's response to emergent but low frequency events, whether that's a natural disaster or a mass casualty situation or a disease outbreak. It's an opportunity, again, to test the policies and procedures, as well as making sure your clinical teams are familiar with the procedures. A major part of disaster preparedness, as you know, is communication and coordination amongst many different groups who are responding to a disaster. And the goal here is readiness. There are several examples in the literature when COVID broke out of hospitals and teams using simulations to better understand how their clinical processes, their workflows, even the flows of people through a clinical space needed to change in order to reduce the risk of virus transmission. There's also some great examples, and I've heard some narrative examples. For example, one hospital in Toronto was rehearsing their mass casualty process and the way their hospital would respond if there were a dozen or more people critically injured all at once. And just a couple of weeks later, there was a mass casualty incident in the catchment area for that hospital, and they actually had to put into place what they had rehearsed as a system just a couple of weeks earlier. And I recognize this isn't strong evidence, but the story, the narrative out of that was about how smoothly the response ran to that, because it had been rehearsed not that long ago. Another is adopting new technologies or treatments. So when a new therapy or treatment is adopted, that can sometimes mean a pretty major change in the way people are used to doing something. And we can use simulation to help a system adapt to this new change. That can be done before actually adopting or implementing. So even as part of the procurement process, you could have real clinical teams run through simulations with new devices. Let's say you're looking at changing a particular device and there are 3 candidates on the market. You work with your teams to set up simulations where they use each of those devices in the simulation and you get their feedback on them. And then once a decision is made to adopt a new technology and implement it, the simulations can help the teams prepare for implementing that. You can test how it's implemented and the policies and procedures around it before it goes live, and identify problems before it does. A nice example from the literature here is one on intraoperative radiation therapy. And you can imagine by bringing radiation therapy into the OR, it's a major change in an OR workflow, because not only are you integrating different hospital systems like the radiation therapy team and physicists and radiation technologists and oncologists, but you're integrating that with the surgical team. And so you want to make sure that integration goes smoothly. A final one is safety culture. And this dovetails quite nicely with the previous talk about how the culture of a healthcare organization can determine how likely people are to speak up when there's a problem or to disclose an error when it happens. And sometimes the problem with the system isn't technical, but it's social. And by using simulations to understand or change a social system, you can better understand what social norms are potentially interfering with better patient outcomes and a more just culture of patient safety. And you can also use those simulations to introduce or normalize new behaviors, new ways of doing things that may not reflect the normal professional or social culture in the institution. The goal here is culture change, of course, and a great example is speaking up, empowering people who are typically seen as lower on a power hierarchy in hospitals to be able to speak up when an error is potentially being made. There's some evidence already in healthcare of the value of this. There's tremendously strong evidence in aviation for this, and the ability of any of the staff on a plane to speak up when a pilot is potentially making an error. I wanted to leave you with a few key papers here. Mirette Dubé, the lead author on a couple of these, is a close colleague of mine. I've had the honor of working with her to put together a course that Simulation Canada offers on system-focused simulations. She's published a ton of work and great advice on doing this. The last paper there, Vic Brazil from Australia, is certainly a global leader. I saw a tweet from her this morning that she's actually in Stavanger, Norway, working with Laerdal right now to develop translational or system-focused simulations with them. And her work is really at the cutting edge of this as well. So again, thank you so much for inviting me to join you today.
Thank you very much, Dr. Willett, for this very useful and very interesting lecture. We present the policies and procedure to can mitigate the human factor. Really, thank you. It's a very, very important and amazing lecture. I see if we have a question in the chat. No, not really. We don't have the question. I think that the lecture was very clear, and I think we should and we must have the policies and the strategies to avoid this factors error in our institution, and nothing will be led to the chance. We should have the policies and the strategies. Thank you very much, Professor Willett, and
my pleasure and my honor. Thank you for inviting me.
And I hope have you in another time. Thank you.
A question did just pop up if you'd like me to address it.
Yes. Okay. Yes. Among the different methods you've talked about, which is the one you think should be implemented in priority?
That's a great question. Seeing as this is a different application of simulation, if this is new to your team, I would suggest starting with something small. So maybe testing a certain policy or procedure. in order to get your own team used to running this kind of simulation, because the setup is slightly different. The way you run a scenario is different. The way you debrief it is different. But then if you're looking to expand it, I think the power here is really if you can understand where some of the weaknesses of your own hospital or clinical setting are, if you know there's challenges with safety culture, if you know that your door to needle time for stroke could be improved, then focus on where you know there's opportunity for improvement and try to integrate some of these simulations into your quality improvement process for that problem. There's a question about sharing my presentation, and yes, I'd be happy to send the file to Morocco Sim for them to distribute.
Thank you very much, Dr. Walid. Thank you. And now it's my great pleasure to introduce my dear friend and inspiring friend, Professor Mariam Fortassi. Professor Fortassi is an expert in medical education, particularly in the development of soft skills to optimize teamwork and communication in healthcare. He worked as the pedagogical coordinator of Morocco SIM has been pivotal in integrating these skills into simulation-based training program. Thank you, Mariam, to be with us today, and the stage is yours.
Thank you. Thank you very much to introduce me. Assalamu alaikum. Hello, everybody. It's a great honor to be here today. Just give me a moment to share my presentation.
The topic will be what role the soft skills play in optimizing teamwork and communication. Thank you.
Okay. Just a moment. Oh, yes, it's coming. Can you see the presentation?
Yes, okay.
Okay, perfect. So, hello again, everybody. My name is Mariam Fortassi. I'm a medical teacher and a medical education enthusiast in general. First of all, I would like to thank Morocco SIM and its president, Professor Mohawi, for giving me the opportunity to practice my favorite activity, which is to advocate for soft skills in healthcare professions education in general, because they play a major role in patient care. So, as you might have noticed, I made a slight change to the title of my presentation, what is the role of soft skills in enhancing patient safety in general, and not only in communication and teamwork. And you'll understand through the presentation why I made this choice. Well, patient safety is not a new concept, even if it seems to be new to the medical community, but it has been part of the medical profession practice and concerns since the antiquity with the Hippocratic principles and ethical main principles as primum non nocere that could be found in the very early versions of the Hippocratic Oath. Then years later, until 1999, was published the famous report, Is Human Building a Safer Health System by the Institute of Medicine, and which was really a turning in the history of patient safety and how the medical and health professions community in general was aware of the importance of the medical errors, their commonality. It was not only some bad people who did not not follow the rules and made fatal mistakes, but it was a very common possibility to make mistakes or errors. The report also highlighted the importance of the cost of those errors in terms of human lives and in terms of financial cost to the community. And also what was really important is that it highlighted the fact that most errors could be preventable. So how to prevent these errors and what to do. After that, like 20 years after the report was published in 2019, that the World Health Organization established the 17th September of each year as a World Day of Patient Safety under different themes. And the very first theme was to speak up for patient safety. So all of these elements led the medical community in general or health professions community to have a kind of shift of culture or a shift of awareness from the errors as being the consequence of some bad medical professionals who do not pay attention enough into a more complex problem that would include not only the human factors, but also the whole system, the possibilities, the equipments, the shortage in human resources and in every other kind of resources. So yes, to err is human, that's something we can accept, but to cover up is unforgivable, it could be criminal. And what's really more important is to learn from the errors in order to prevent other errors from happening. This leads us to focus on the core competencies or the skills we need to develop to prevent human errors and to promote patient safety. Of course, or obviously, we'd find, for example, clinical knowledge. And clinical knowledge might be something obvious that, of course, a physician or a nurse shouldn't be allowed to practice until they have gained enough clinical knowledge that would allow them to practice in a good manner and not make a lot of mistakes. But this is not the case in every country. In some countries, they have regulations that would have a regular assessment of practitioners to check regularly their level of knowledge, if they have continuing medical education, making them mandatory to keep your practicing license. But in other countries like mine, all of these aspects are not really regulated, which puts a main, it makes the clinical knowledge as one of the main causes of possible errors. Technical skills also. Regulatory knowledge, and to blame regulatory knowledge, we need to have regulatory procedures set before, like the guidelines, the procedures, the processes that help the practitioners follow the protocols. Of course, we need to know the risk, how to evaluate the risk assessment and risk management. Also, infection control. All the practitioners in general need to have basic knowledge about how to control an infection, which represents one of the sentinel events that are mostly reported in patient safety reports. But also, we need to develop effective communication, teamwork, and collaboration in order to enhance or in order to reduce the risk for errors. We need to develop our emotional intelligence to be able to work as a team, the critical thinking, because in the previous presentation, it was a matter of awareness of the situation or awareness of the risk. And without critical thinking, practitioners would not be able to accurately assess the risk or the risk of the situation itself and be able to report the problem. And of course, we need to develop some leadership skills in order to be effective in leading the teams and in following the leader of the team. So now, if you want to be to have a broad separation, we have on the left what we call hard skills, and those are called hard skills because they can be measurable, quantifiable, and teachable in some formal educational settings. Whereas in the right half of the screen, you have what we call soft skills. They are called soft skills because of the subjective aspect, their subjective aspect, the fact that they are difficult to measure and cannot be taught. We cannot teach them in a very formal classical environment, but they need to be learned in some specific environments, including simulation. Well, what attracted my attention is, I mean, this number might be obvious to many of you because we've heard this a lot, like most medical errors and most problems are linked to miscommunication. Many papers and many reports are citing the Joint Commission, which is an institution that reports or that receives and classifies, collects data regarding sentinel events in the United States. So it is cited as being the source of this number, that most or the majority of medical errors are linked to miscommunication. And this led the medical education community to develop many programs and many techniques and many sources. Some sources were developed even before collecting this data, and some are implemented, like, for example, the SBAR technique that we all know, stating clearly the situation, background, assessment, and recommendation when providing a situation, when communicating about a patient situation, and there are many other communication techniques like the STIC protocol, situation, task, intent, concern, calibrate, or the RELATE protocol, reassure, explain, listen, answer, take action, and express appreciation. So those protocols and many teaching or educational programs were implemented in health professions education curricula in order to enhance the ability or the good communication between the health workers, based on the fact that data is telling us that communication is the main problem. However, a very interesting study that I found while preparing for this presentation, it was published in a very leading medical education journal, which is Medical Education, and it's about debunking the myth that the majority of medical errors are attributed to communication. Well, the story of this systematic review is that the authors, who are medical educators, were asking themselves, how come that even after enhancing good communication and effective communication among healthcare workers through the educational programs, the numbers of medical errors attributed to miscommunication are not going down from one report to another, from 1 year to another by the Joint Commission reports. So they were saying maybe there is a misunderstanding or a misattribution of the core cause of the problem to communication, whereas it's linked to other skills or other soft skills or other problems. And they made a systematic review and included 42 papers that were reporting medical errors. And from these papers, they found that only 17% of the reported medical errors in these papers were directly linked to miscommunication, whereas in the other situation, there were either errors of commission or errors of omission. Well, to give you an example, let's see this case study. For example, if during the routine morning round, the attending physician notes the patient's lab results indicating elevated potassium levels. Concerned about the risk of cardiac complication, the physician decides to change the patient's medication from a potassium-sparing diuretic to a different diuretic, which is obviously should be a potassium-sparing. However, in a rush, the physician communicates only that the medication should be changed without specifying the exact new medication. What happened? The resident, under pressure and thinking of alternatives, misjudges the physician's intent. Instead of verifying the new medication, they assume it should be an existing diuretic in the patient's medication list and change for the same class of diuretic. The nurse staff administers the incorrect medication, which inadvertently worsens the patient's potassium levels. This oversight leads to an acute cardiac event that requires emergency intervention. Here, you tell me the cause is miscommunication because the attending physician wasn't clear about the diuretic they wanted to introduce. They only said, I need to change this diuretic without explaining the reason and without specifying which one. Yes, we can see, I mean, apparently it appears as a miscommunication problem, and miscommunication is part of the problem, but is not the only problem. What are the other causes? The misjudgments. I mean, the resident, because they had some doubt about the intended molecule, they should have asked the attending physician to clarify, but they didn't do so. Why? Didn't the resident ask or confirm with the attending physician? Maybe there was a bullying environment in the workplace. Maybe the resident wasn't self-confident enough. Maybe there was an assertiveness problem. Or also, we have this rush decision-making. Maybe they try to reconfirm with the attending physician, but the time was lacking and someone went home, for example. Maybe it's a problem of a lack of assertiveness, and this is linked to the nurse. The nurse knows that this is the same class of antidiuretic. She could have asked why. Sometimes the nurse would just follow the orders without asking, even when they have doubts, and this is a problem. It's not a pure communication problem, it's an indirect communication problem. The ethics, which is considered as a soft skill too, to be developed and taught to our future doctors and nurses, may be part of the case presentation I just mentioned. Why? Because if the resident had high ethical value, they would not, for a doubt, they would verify. I mean, the question, if you want to ask the question differently, would the resident act the same way? Would the nurse act the same way if the patient were one of their relatives? Maybe not. Maybe they would have taken the risk to verify. And finally, the critical thinking. Maybe the nurse was not aware of the situation. Maybe the resident was not aware of the situation. Even if the critical thinking here, I mean, it doesn't apply exactly here because we're not discussing about being aware of the gravity of the situation, but rather the taking the decision to ask about specification. Just like this example, there are many other examples. For example, when a patient gets surgery on the wrong side, he was intended to get surgery on the right leg, but he got it on the left leg. Apparently, we say it's a communication problem because the nurse or whoever brought the patient to the operating room said it's the right side, but the surgeon had to verify, to go by the protocol, to check, to re-verify radiographs or the patient, go through the patient record and verify. Not verifying might be due to time management problems, to a lack of professionalism, and all of those are soft skills that are not directly linked to communication. If a patient falls from a bed, maybe it's an omission error because the attending nurse didn't put the barrier correctly. Why she didn't do because of misjudgment of the risk, or like the risk assessment was not done correctly. So when you analyze all of these medical errors, we can see that some of the skills lacking or leading to such consequences might be omission of following protocols, no double checking, no well-defined procedures, already lack of clinical knowledge, or some cognitive impairment. For example, after a shift when someone is not paying attention enough or is sleepy, or a memory shortage. All of these are part of the hard skills, but then underline, we find the lack of empathy. We don't really feel the patient's suffering, to take their suffering seriously and go verify, do whatever it takes. Ethics and integrity, critical thinking, conflict management. Yes, maybe the nurse didn't want to double check with the resident because there was an unresolved conflict going on. Assertiveness, time management, stress management, adaptability, and mental flexibility. Here, I want to transform the medical skills iceberg from this aspect where you find that the skill knowledge is the seen part of the iceberg and the soft skills are the unseen parts, into this. If we want to build an iceberg of the soft skills, we'll find communication and teamwork on the top, but some other skills that are less visible, less valued, but not less important are emotional intelligence, leadership, ethics, resilience, patience, flexibility, and empathy. When we go, for example, if you do a research on PubMed or any other resource, you'd find hundreds or thousands of publications regarding communication and teamwork, but very few regarding all the other major soft skills that need to be addressed in order for this communication and this teamwork to be effective. So also when we consider patient safety as a whole, we can see this comparison between hard and soft skills. For example, when collecting data, when addressing patient safety, one of the core things to do to promote patient safety is collecting data and reporting errors. When we're collecting facts, that's the hard part of what we're doing. But then what about emotions and feelings? As we do in the briefing in simulation, at the end of the scenario, we ask the participants about their feelings, their emotions, but do we do that when reporting a medical error? Reducing the risk, for example, it would rely on management and control as an authoritarian approach. How about building trust and engagement of the teams? This is the soft parts. And delivering medication, for example, because patient safety is not only linked to hospitalized patients, but also in consultation and outpatients, you can prescribe and recommend treatment. But how about convincing and negotiating with the patients so that they have compliance with this therapy and they take it? In order to improve patient safety, of course, we need to build programs. I mean, it goes through education, and many KIPS programs have been built and delivered in many institutions. KIPS stands for Quality Improvement and Patient Safety Programs. But in developing a KIPS program, which is what we're trying to do in Morocco, we need to take into consideration many concerns and take into consideration some challenges. Some concerns were already mentioned by the Center for Quality Improvement and Patient Safety of the University of Toronto. The first is multidisciplinary teaching. We need to have teachers from many backgrounds, from humanities, social sciences, to teach our students the quality improvement and all the soft skills aspects in order to develop an effective communication and to give a broader impact that's outside the limited frame of the medical practice. We need to have a theoretically informed education, like base this education on the theories that underlie its importance and not just teach for teaching. Integrate teaching of soft and hard skills. Soft skills are well taught when they are taught in the context of hard skill and not separate them in a separate scenario. Within the same scenario, we need to evaluate and teach and try to collect and discuss what's the part of the hard skill of the technical procedure of the clinical reasoning and the soft skills that goes with it. And of course, suggesting meaningful assessments. Of course, we have many challenges to implementing those kind of programs, and we don't have one really officially established in Morocco, but we're advocating for that and aiming for it, especially within the context of this medical reform going on. The challenges are, for example, the lack of awareness, including lack of interest, engagement, involvement of the teaching staff and the institutions, administrations. Conservative disciplinary organization of higher education, the resistance of change that we all suffer from whenever we want to add something, there is no enough place. And of course, the need of funding, the work pressure, the lack of time, we need to find some time more, find funding for this kind of curricula to be implemented. And finally, we ask, should it be included within the initial training or continuing education? Should it be included within the undergraduate or postgraduate program? And I would say all of them, both within undergraduate and postgraduate. And I'll finish with this, just mention to a guide that we developed that would be published shortly. It's a guide for undergraduate medical students to develop core competencies in medical leadership, including all the necessary soft skills that they might need in their future medical practice. And I finish with this very nice quote from Simon Sinek: "I really reject the idea of soft skills. There is nothing soft about them." He's truly right. We have hard skills. And we have human skills. We need more human skills, I'd say, in healthcare today. Thank you.
Thank you, Mariam, for this clear and amazing presentation and lecture. And I want really to thank you for all what do you do for this spread of knowledge on soft skills and implementing the soft skills in our practice. The question, we have two questions in on the chat. The first is when should soft skills ideally learned? It is after mastering psychomotor skills. Question of Kamal.
Yes, yes, thank you for this question. As I said in my before last slide, soft skills should be introduced from the beginning, from the first year, but in gradual levels, like the basic soft skills in first year, and then we progress in the levels within the years of studies.
Another question from Kamal also. It's please another question. Can you tell us more about sharing mental model among a multi-professional healthcare team? Thank you so much for your excellent presentation.
Okay, thank you. Well, the sharing mental model can be a good way to enhance communication among a team, a medical team or a multi-professional team. So yes, it's a good tool to master and to use. I really encourage using it.
We have some in the chat some. It's not the questions; it's some attendees who are very grateful, and they say that thank you so much, Miriam, for this impressive lecture.
Thank you. Thank you so
Thank you,
much.
Miriam. Thank you.
Thank you.
And at the end, I just want to resume and the lack of safety in the care pathway, it's unacceptable. Unacceptable. And we have clearly seen that human factors can be a real source for insecurity. We must integrate these modules very early into the academic curriculum, and therefore having strategies and procedure is essential. Ultimately, soft skills are a crucial aspect for our practice to improve the best and safest care possible for our patient. Thank you for our three speakers. There was an amazing session, and thank you, Morocco Sim. Mohammed. Thank you.
Thank you very much to Professor Orio Denis, the reference in the briefing, with his book on the matter. Thank you so much to Dr. Timothy Willett. Thank you for putting the spotlight on the importance of system simulations in system simulation and system integration. Thank you to Professor Miriam Fortasi. I doubt there will ever come a day where I won't learn from your presentations, the advocate for soft skills in healthcare. Thanks to Professor Nsari Afaq for perfectly managing this session. Thank you all for your presentation, for your thought-provoking presentation, and I will leave you for a lunch break that we're gonna be around 20 minutes. See you then. Welcome back. I hope you had a refreshing break. As we approach the conclusion of this remarkable event, I am excited to present the fourth and final session entitled Innovation and Future Directions, and its chair, Professor Shli Hamel, Board of the Moroccan Society of Simulation in Healthcare, past head of the Department of Pododontics. Professor Shli is a key player in the Moroccan healthcare simulation community. He has been instrumental in promoting the adoption of innovative simulation technologies and methodologies to enhance the quality of healthcare education in Morocco. Professor Shlieh, please take the lead and guide us through this session.
Thank you so much, Dr. Dervish, for this kind presentation. Good afternoon, everyone. I would first like to sincerely thank Professor Mohawi and the Morocco team for giving me the opportunity to participate in this e-conference. I'm therefore very honored to moderate this fourth and the final session, whose theme will undoubtedly spark everyone's interest. We know that the rise of new technologies has revolutionized simulation training for health professionals and offers today very interesting perspectives for the implementation of more in-depth training. So, what are the latest innovations? This is what we will discover with our first speaker from Lebanon, Dr. Carlos Shidiak, an international expert in simulation in healthcare education. Dr. Shidiak, the floor is yours.
Thank you, Doctor, and good afternoon, everyone. Can you hear me?
Yes, we can.
Thank you. So I will share my presentation, and so can you see my presentation?
Yes.
Okay. So, good afternoon. Thank you for having me. I'm Carlos Chidiak. I'm a medical doctor that dedicated my whole career to healthcare education. I always say that to my audience that I was one of those Generation Z learners who didn't like the way we were taught medicine, and especially in the field of clinical skills, where I really felt like a graduating doctor with a great degree on the wall, but my hands did not have that amount of skills I needed to have to move on. And this is what brought me actually to simulation. And I've always thought about simulation as being, my salvation, and this is what I continued doing since my graduation in 2006. So approximately 18 years now, trying to develop new methodologies to teach Generation Z. And my mission in this career is to listen to the learners. Okay, so learners are really very important, and these are our customers or our clients, if we want to say that. And without customers, without proper customer care, I mean, an industry would never thrive. So looking at education as being a business, so whether we like it or not, we need this to thrive. We need quality to be injected. So I thought simulation is a really cornerstone, and the technology in simulation, adding technology, and this is what we will discover together. This is what I'm trying to promote in my career, and I'm getting really tangible results in that. So that's why I am sharing this with you now. Okay, so my focus have always been the learners and the learners and the learners, and measuring their satisfaction, measuring their learning outcomes, and also measuring their engagement in the learning process, which for me is very important. So as you've seen, I was following all the day. You've seen, a video about a highly robotized, simulator. So our vision here is to have those simulators, those robots being motorized to the last extent, being humanoids. Okay, so why do we need that? We need that so that first, the goal of simulation, and I'm sure many of my colleagues has spoke about this, is patient safety. Why do we do simulation? It's all because we want our patients to be safer. We want the outcomes of and quality of care to be much higher. So that's why we really use simulation and simulators to make everybody safe, the learner, the educator, but also and mostly the patient. So we want the Generation Z to be immersed in the experience. Those simulators need to speak, need to move, need to be like, RoboCop, that movie from the 90s that triggered our dreams as young people in order to, believe in what we see. And in my opinion, having those simulators, or what we call them now as humanoids, having them so realistic, having them like in perfect skin, perfect eyes, facials, anatomy, physiology, as this picture tells you all, you need to be using a real hospital bed with real hospital equipment. You need to be wearing your PPE, wear your anything that you use in your everyday life as a student or as a doctor. So this is how it should be. This is the vision. Realism to its best. Why do we need that? Because Generation Z wants it. In my career, I met so many educators, esteemed educators, including my own educators, and I spoke with them about simulation. And the answer sometimes was deceiving for me. And I was told that we have so many patients. Carlos, you've learned medicine that way. We've learned medicine that we've always been learning medicine that way. And so let's keep doing that. And and this was, I couldn't take this for an answer to me trying to promote simulation. So and that's why, and that was not only me, but a huge community now that uses simulation in education did not take that as an answer. Oh, we have real patients. That we couldn't take that as an answer, and the outcomes are good. Industry is booming. That's why we're not focusing on what the educator thinks, but we focus more about what the learners want. Do they really want to be in one room, 200 people in one room, watching a PowerPoint presentation or watching a YouTube video? I'm doing this now, but there's no other means. I would have loved to be with you there. We still have great outcomes out of live sessions and presentations, but for undergraduate learners and when it comes to skill training, this is not what they want. Okay, so, and this generation is tech savvy, they know technology, they use it. And in my own experience, with all due respect to so many, eminent educators, some educators fear technology. They say it doesn't work. They say it fails. They say it's not reliable. Okay, but technologies are yeah, that's right. That was the case 10, 20 years ago when we started those technologies, but now it's becoming more and more user friendly, especially becoming a tool that is easily used and easily manipulated with this new generation. They were born with technology. They know how to interact with it, and they know how to use it properly. So from that side of technology, I don't think there's a problem. Okay, so and I would like to raise the concept of simulation for stimulation. Okay, we've measured throughout my career and throughout many years of technology development, we've measured the immersiveness and the engagement and the stimulation that those young learners get when they are faced by a really high-tech, realistic humanoid. rather than, you know, a dead stick Barbie, you know, just a doll. And many people call it doll, and they're right. You know, if you have a doll, some plastic lying down, not moving, not breathing, not having pulses, not talking. So I mean, you cannot believe that, you know, and with this young generation, that's even worse. Okay, they won't engage. They would, you know, think it's not interesting, and they would just, you know, do their whatever they need to do and just, you know, move away. And this is really something we don't want to have currently. Also, these robotic technologies you've seen simulating stroke, simulating handshakes, simulating, you know, so many things, physiology, pathology. These are really important because it enables this generation of users to use it with real technology. And with these robots, we say goodbye and forever to those monodactic lecturing methodologies and those you know, assessments. Like, I graduated because I gave the right multiple choice question answers, you know, like A, B, C, D, E, you know, and then I answer the good ones, and then they scan it, and here you go. Get my grades, and, you know, I graduate as a doctor. This is gone. With this technology, it's gone, and we're going to learn in the next slide why it's gone. Those robotics are enabling us, you know, to interact with the students. So it's not only with the patient, robot patient. It's not only, you know, giving some cool stuff. No, it could really react. It could show symptoms of stroke, symptoms of respiratory distress, symptoms of cardiovascular collapse. So it's really so realistic. And, you know, with AI, you know, you can have a patient history, you know, that is strictly designed and standardized to be fair and equal to all students. So with this AI conversation, you can ask the robot about the name, age, past medical history, medication history, food allergies, where are they from. So you can really program the robot to answer through AI, to answer all the conversations, because a good doctor is also a good you know, interactor with those with patients. It's not only the scientific knowledge, but it's also how to gain the patient's the trust, how to start interacting with the patient, and the robot can teach a lot, of course, if it's high tech. And of course, we have introduced in those mannequins and those robots, it's not what only how it looks, but, you know, the amount of technology built in inside those simulators of lung physiology and pathology, heart physiology and pathology, abdominal bleeding. You know, even the skin is interactive now, capillary refill, the airways, you know, becoming, you know, anaphylactic shock, go surgical. Plenty of things have been input in these simulators. Even internal organs, as you see in this picture, you can do ultrasound on patients now. Okay, so this software powered ultrasound, you can do endoscopy, you can do surgery on them. So they're going wild. So really can be treated as real patients, and you can learn a lot about the human function with those advanced robotics. I really advise everybody to consider this methodology, to begin with this technology, you know, of having advanced robotics, whether in adult, as an adult patient, neonatal patient, obstetric patient. So in whatever discipline you try to teach, ultra high fidelity robots, what we call humanoids, are really a necessity in modern practices simulation. Okay, so then next I move to the augmented reality, which is, in my opinion, very, very, very amazing. And Generation Z, I mean, you should look into the eyes of these guys, you know, when they see you performing with this headset on your head, and teaching them with an interactive way, and then having them try it. I mean, that's another set of skills. That's another world of didactic education. So these are computers. They have screens in front. They have cameras to read your hand movements, and they have a computer in the back of the head where all these, you know, graphics are shown and generated, and we call them holographs. And So what's amazing about these technologies is that you can give them to students. So you can use them as a teaching, you know, as you see in the upper picture. So you can use them as a teaching methodology. So it's like a tool that would enable students first to stimulate students to learn, stimulate students to pay you attention. And of course, it's like a see-through glass where they can understand the anatomy, physiology, and pathophysiology on top of each others, okay? But on the lower pictures, you can see that learners could take these headsets, you know, for half an hour, for an hour, and then sit with themselves and, you know, learn about all the emergencies, learn about normal delivery, learn about, you know, airway management, learn about hemo and pneumothorax, abdominal bleeding. You know, there is plenty of modules, anatomy even, so they can learn a lot, you know, during this learning process. It also, when they use it for when they use it for because it's called augmented or reality or mixed reality, then when you use it as a mixed reality, you can have your headset and look at the mannequin, and then you can enjoy haptics. So you can be touching the mannequin, you can be touching the anatomy of the mannequin, but also see through, and you know, it helps you and guides you throughout the processes. Okay, so it adds on to the classical teaching. You can do serious games, so it's like the theoretical learning and teaching before students become confronted with real life, so they can play games. It's like when you give your child a PlayStation or an Xbox to start playing football, and then with time they start, you know, learning the strategy, but at the end they have to go and play on the field. They have to sweat, they have to shoot the ball, they have to appreciate the aggressiveness, you know, of the environment, the real environment. But it's always good to learn on a software before you go there. Okay, so you can see all around, as I said, those screens are transparent. You just have the add-on, but you still can have the haptics are there. You can combine the graphics with the real patient or robot, and then you have the best combination for muscle training along with theory training, you know, memory, the regular brain memory training. So you can use both. And of course, you are in an environment, so you don't need, it's the real environment. You can see the real monitor, you can touch the real bed, you can have a real needle and work with it. So it's just, you know, these augmented reality techniques helps you add some internal perspectives of the patient, internal anatomy, for a better understanding during learning. Okay, so, and it's again, Generation Z, they love it. We've had a lot of tons of research about this. It also, when they start learning, it preserves their psychological safety. So because when they put this headset, it's them and themselves. You know, they are learning alone. It's in privacy, because there is no risk for peer pressure, and therefore they can do mistakes and get guided by the software, and you know, they can get even better and better when it combines with the mannequin, and they start understanding better the anatomy and the physiology, and of course haptics. You know, nothing replaces haptics. We are human after all. We are humans and treating humans, so we should be using our human senses and touching human beings, and then, you know, get the learning process really getting there. What are the advantages and disadvantages of you know, robotics and AR? Of course, it's the development, it's the technology, it's how much money you put in, you know, and of course you always have limitation in the amount. So you can order a robot now and maybe get it in 3 months. So it's on high demand. It requires a high budget, but you know, you can always start planning for it and get it, you know, in always less than a year, you know, and get ready to use it. Last but not least, I would like to speak about you know, the learning management systems. And this is, if you ask me about new technologies in simulation, okay, so that's a cornerstone. Because if you do plenty, hundreds and dozens of simulation activities. Who would track and trace those? Who would organize those? You know, I always give the example of a really busy airport, you know, people checking in, printing luggage tags, getting their boarding passes, you know, with so much details, flight number, seat number, whatever you want, and then go stamp your passport. Imagine the amount of data and organization that needs to happen in an airport. Imagine an airport operating without a software, without a system. You know that, you know, this is your bag, this is your flight, this is your passport, you're going in and out. And it's exactly the same when you have a modern and active simulation center. You cannot do it with hundreds of students, with dozens of courses, and you know, all of those practices and educators and courses and syllabi you need to apply in the sim center for clinical skills. You cannot do that without the technology of learning management system, which is only getting better. With AI tools now, we are talking about AI. It's there. It's now you can use it. You have lots of, you know, assessment tools by AI. You know, especially those conversational AIs where you can interrogate a patient, and then depending on the sequence of your questions, depending on your reactions, depending on your answers, the AI can auto assess, you know, the student, which is also relieving some precious educator time. Educators are rare. Educators are becoming scarce. So you cannot always find enough educators, right? With this growing demand on healthcare education. Also, it organizes the posting of learning materials. So if you need your students to read some materials before coming to the courses, this is the platform where you can do this. It organizes the faculty and the facility and the student access. You know, in the modern sim centers, you could have up to 20 or 30 rooms, you know, excluding OSCE. So you really need to put the right instructor in the right room for the right course for the right, you know, group of people. All of this is a great management. You know, you cannot put 200 people in one room in simulation. Okay, so also the audiovisual recording. So modern simulation, you just record your students' performance. You just allow them to debrief, to watch themselves, and to auto-criticize. You cannot point fingers anymore in debriefing. So students have to auto-assess, and of course, the facilitator should help them. And what best it could be, but with audiovisual and camera recording, it's giving amazing results. Students love it. Generation Z loves videos. They love to see themselves performing, and they get encouraged to, you know, write their own assessments. OSCE, of course, you know, when you have 12, 18, 24 OSCE rooms, I mean, and those students rotating with SP, standardized patients, and so many, you know, criteria. I'm sure most of you practice OSCE, and you know how hectic it is to do it on paper. It's still doable on paper. I see so many people do it on paper, but I really encourage you to try the new technologies that have all the banks of stations, all the banks of assessment sheets there organized. It's just, you know, mix and match. And the results of every OSCE session is just a finger click away. Okay, thank you so much for your attention. And sorry, and so we have a lot to show you, but you know, due to the shortage of time, I would like to be open for questions, and I hope that my information had opened up some imagination and vision for the future for everyone. Thank you so much.
Thank you, Dr. Shidiak, for this brilliant presentation, which shows us how all these advancements can improve, and especially for current generations of learners, the realism of simulations, expand accessibility, and enhance data collection and feedback mechanisms, and ultimately leading to safer, more effective healthcare practice. we will see if we have some question for Dr. Chidiac. We have a question from Riyad Bezawi, who's asking, thank you for your presentation. I have questions. Are you not afraid of new technologies and their impact on employment?
Well, that's a great question. I mean, I mentioned this in my presentation, and thank you for your attention on that. We are always in shortage of educators. This is all over the world, and you know, if it takes you know, to double up your faculty, everybody would love to, and because it affects quality. The more educators you put in the system, the more quality you have in education. I think we cannot wait until we can double up our faculty. If we use the new technologies in assessment, in education, we would offload a lot of, you know, duties and a lot of job scope from educators, but this would never be enough. And with assessment, it's not about, you know, the fear of employment that is what is of importance. I think it's about the fairness. It's about standardizing the assessment. You know, when you are a human, you are always subjective. You could get, you know, influenced by some situations, but when it's technology assessing, it's fair for everyone. It's just, you know, a technology that is standard to everyone, doesn't have a prejudgment, does not get humanly affected. And I assure you that we could find 100 other tasks for our employees to do. Employing technology is only adding to the quality. It's not replacing the actual employees.
Okay, it's we haven't any other question. So thank you once again, Dr. Chidiac, for your presentation. And if you don't mind,
With pleasure.
And without further delay, I invite Professor Bensouda Adil, Dean of the Faculty of Medicine at International University of Rabat, Morocco, who will enlighten us on how will simulation evolve to meet the future needs of healthcare education. Professor Bensouda, the stage is yours.
Good morning. Do you hear me? Do you hear me?
Yes, very well.
Okay. I will share my do you saw my slides?
Yes, it's clear.
It's good?
Yes.
Only the slide or the speech also?
The slide only.
Okay.
Just on the side, yeah, we can see the right side. That's there.
Professor,
The narrative, it's there, yeah.
Professeur
So-
Bensouda?
Oui.
Professeur, comme tout à l'heure, vous partez sur
Oui.
paramètres d'affichage et vous, comme tout à l'heure,
Alors.
comme vers le haut. Since we are able right now to see your speech, so if you want, if you can, just little click on paramètres d'affichage on the
Je
top
suis
of
en
the
train de-
page. Yeah, that's right. On the top of the page of the screen.
Juste en haut du curseur.
Yeah.
Vous êtes...
Another little movement. Paramètres d'affichage. On peut l'aider? Alors, oui. C'est Bensouda? Non, non, pas
Oui.
non stress. So, d'abord, la diapositive, la présentation خارجة ياك, c'est ça?
Ouais, et ok,
خارجة.
non.
Mr. Bensouda, tu as arrêté le partage d'abord ياك?
Oui.
Vous avez arrêté le partage. OK. Alors, on va ouvrir, repartage une deuxième fois. Allez-y.
D'accord.
On y va doucement. C'est perfect. Allez-y. Go ahead. And we wish you the best of luck.
OK. Just to remove something là, il y a des choses qui me gênent dans mon écran. Est-ce que vous voyez le tout ou c'est juste les slides? Vous voyez également le texte, le speech?
Non, non.
On peut y aller comme
Just-
ça?
On ne voit que la présentation, c'est bien.
Okay. So, good morning to all colleagues around the world. I would like to present my gratitude to Morocco SIM and his president, my brother, Professor Mohawi, and all the participants of this webinar. Also, my thanks to Madam Chairman. And today we'll be explore an important topic related to simulation and how it evolve the future needs of healthcare education. Many things have been said this morning and this afternoon, which is why I will focus on what is being done in Morocco and more specifically at my faculty. I don't have any conflict of interest. First of all, I would like to show some photo of my city. Rabat is a pleasant city with a great quality of life, a city of paradox between calm and expanding activities. What's the situation, very summarized, of health in Morocco? We can observe that population growth. We observe also that the national ratio is of 7.5 per inhabitant, and also expanding. We have, of course, expanding healthcare coverage, and we have an imperative. We have a crucial need of a robust healthcare system to support the emergence of developing economy. The challenge of health care education is we have two important points. The first one is to increase the physician to inhabitant ratio, and the second is to maintain the level of competence of doctors. And how can we achieve these objectives? We can achieve this objective by focus on shortening of study duration, by increasing the number of medical students, by modifying the curriculum, and additionally, by increasing internship opportunities and promoting pedagogical innovation, and which is a crucial step toward these goals. This is a very interesting work recently published by my colleague Karim Al-Ghazi from Fez University, and I would like to thank her for this very good work. And this paper tried to find the correlation between medical training duration and the QS score of universities. And we see that they have a positive correlation between the longer training periods and the high rankings in countries such as US, UK, Canada, or France. This correlation is not statistically significant, but it's positive correlation. And however, the top-ranked university in places like Singapore and Netherlands or Germany maintain a shorter training duration. So there is many situations, some countries with the long duration of study and others with a short duration of study. But if we have in global analysis, we can show that more the QS is elevated, more the study is prolonged. And in this paper, we can also note that there is no significant correlation between training duration and the ratio physician to population. So there is several factors aside from the length of medical training, which determine the physician to inhabitant ratio and which determine the level of competence of doctors. What are these several factors? The first of them is the number of medical schools. And currently there is 20 medical faculties in Morocco, and this is most of them are public and a couple of them are private. And we can act also on the curricula content. We can in the same time act on practical training and on pedagogy to try to improve these two parameters that I spoke about, the physician to inhabitant ratio and the level of competence of doctors. But as you know, the conventional learning, which is widely used for years, now it shows some limitation. And as you know, lecture-based teaching requires simultaneous availability of teacher and students with limited interactivity, and lecture-based teaching reduces time at the patient's bedside. In the same manner, we have a risk of mistakes on real patients, and we have inability to repeat procedures for improvement, and we have an incomplete exposure to rare pathologies during training. So as Madame Bentalha said this morning, and I would like to tell her thank you for her topics, for her conference. We have in one hand a passive learning and in other hands active learning, and we promote and we will promote the active learning by innovation, pedagogical innovation. So this is a picture of lectures and the consequence of lectures in the auditorium, which can be sometimes soporific and the consequence that we have two challenges in medical education. The first challenge is the growing number of medical students facing a shortage of internship placements. And the second challenge is the reduction in the duration of medical study. So how can we do facing these two issues? So healthcare simulation education could be a key part of the solution. This is a photo of several medical interns around a patient who sometimes refuse this situation. And our ideal is to have one student per one hospital bed. But the situation with the growing of the number of students, of medical students, that doesn't allow us to have this situation of one student per one bed hospital. Indeed, in this review by Omar Ayaz, published in 2022, it is advocated that healthcare simulation is becoming an integral part of medical education by enhancing clinical skill in a safe environment. And global changes present opportunities for simulation to expand, and future research should prioritize its resilience in low and middle income countries. In light of this, we have to consider the key features, the key features and best practices of simulation-based education, which include mastery learning, feedback, deliberate practice, skill acquisition and maintenance, and of course, team training. Looking at this graph, we can see the learning curve of a typical medical student. This graph highlights the role of simulation in shortening training time for essential skills. You can say that we can buy the time. And by incorporating simulation training, medical students are better prepared, quickly prepared, safer, and more confident when working with actual patients. Additionally, this slide illustrates Bloom's taxonomy of cognitive domain. It highlights the progression of learning students from the knowledge to comprehension to application, and then to analysis, and then to synthesis, and finally to evaluation. And of course, simulation, as you can see here in the faculty hall, you can see the simulation exercise. And this slide shows how students in CPR simulation, and of course, this allows us to be in conformity with Bloom taxonomy. Simulation also give the opportunity to have effective team working, and moreover, simulation enhance communication, enhance collaboration and decision making among team members. And this is for me the opportunity to address my gratitude to the organizing team of Moroccan Symphony Orchestra. So if you want to implement a simulation program, you have to respect these five objectives, these 5 steps. First, to define objectives. The second step is to identify researchers by organizing roles, gather equipment, recruit staff, and secure funding. The third step is to develop educational activities. The first step is to implement the program and evaluate its content. And finally, to assess effect by measuring the short-term feedback, medium-term knowledge gains, and long-term impact on professional development. Globalization is also an opportunity for simulation, because simulation allows for standardized training in response to such pathologies, ensuring that healthcare systems worldwide are prepared to respond to global health threats in coordinated and effective manner. And just as an airline pilot receiving international training, doctors should be prepared in the same way, because pathologies today is cross-border, and the easy travel leads to prepare us to be international doctors and not only national doctors. So how will simulation shape the future needs of healthcare at my university? This is a modular organization of medical education 2024, based on 12 semesters, and each semesters is include 7 to 8 modules, and essentially 5 disciplinary modules, 1 modules with the 2 mandatory foreign languages, and 1 power skills modules, and finally 1 clinical internship modules. This slide outlined the module description, and this is very important slide because we can focus on the localization of the simulation. And here you have the module description, and in the first chapter, in the first chapter we have module syllabus, and in the second chapter we have evaluation, and the third chapter you have the coordinator of the teaching team. if we take in account the module syllabus, you can see that at this part you have one section related to organization and practical activities. This is very important section, and you can put here what you want to organize as a simulation, in situ simulation or in lab simulation, and the number of hours that you allow to this component. So in my faculty, we try to put a broad simulation session in each disciplinary models. So we can introduce, we introduce simulation workshop from the first year of medical study, and we incorporate simulation into weekly hospital internship once a day, and in the other 4 days, the students go to the hospital internship, and we promote the broad integration of simulation across the module in the curriculum. For example, we can integrate for the cardiovascular model the 3-degree atrioventricular block in the cardiovascular pathology model. Here we are, the illustration of a day at defibrillation day at University International of Rabat, with some photo about the students in their symposium of defibrillation. And here we have a non-exhaustive list from which we draw the most frequent scenarios that can be used. And for example, in respiratory models, you can choose, for example, acute pulmonary edema scenario, amniotic fluid embolism scenario, chest tube malfunction, etc., etc. Executive education is also very important for the future of simulation. And we also have a trainer training activity in collaboration with Morocco SIM. And for me, it's the occasion to address a big thanks to my brother, Si Mohamed Mouhawi, because he was with us at this symposium last two weeks ago. And we work also with the CESAR Center from Grenoble University. Evaluation, it's very important when you have a simulation program integration. And we outlined here the method for simulation evaluation. And we include an anonymous survey assessing learning satisfaction, safety, and educational quality. We can use the Likert scale. And we also include a course-specific survey and an instructor evaluation tool to assess teaching effectiveness. Research, it's also very important when we want to integrate a simulation program in healthcare education. And here we have two strong recommendations. The first one is conducting research to assess the impact of simulation on professional practice and patient care and outcome. And the second recommendation is to explore research partnership with other departments, faculties, and institutes. Many thanks here to Dr. Umayma Shangiti, our PhD in simulation, and this is a couple of her publications. Can we return back to my slides, please? Can you return to my slide, please?
You can share it.
Ustad Bensouda?
Oui.
I think your lecture is not more shared. If you can reshare the lecture,
Okay.
And it will work. Okay, so just try to do it. Just as the first step. Okay, that's right. Go
Okay,
ahead.
we can continue.
Yeah, of course.
Okay, thank you very much. So it is important to note that we must correct the perception of simulation as university expensive commodity, and I would like to say many things else, because many speakers have already addressed this aspect. Regarding to legal framework, healthcare simulation is recognized in reference documents supported by scientific societies and supported by the High Authority of Health. However, in Morocco, there is currently no specific law regulating simulation as an educational technique, but this activity is fortunately strongly supported by two Moroccan leaders, as Professor Belyamani Lahsan and Professor Si Mohamed Mouhawi. And in conclusion, my take-home messages is that the aims of healthcare education is to produce competent practitioners who provide safe and high-quality care. Finding the optimal methods to achieve this goal remains is ongoing challenge. Efforts continue to refine the use of simulation in healthcare education for greater effectiveness, and research play a crucial role in improving education practices and patient outcome through simulation-based healthcare education. So thank you for attention, and you're always welcome in Morocco. Thank you, Mr. Chairman.
Thank you very much for the richness of your presentation, Professor Bensouda. You indicated that simulation must be introduced to the curriculum in all disciplines. And you indicated also in your presentation that simulation in healthcare will continue to evolve, providing accessible and effective learning experience and improving patient outcomes. We'll see if we have some questions. Yes. We have a question from Dr. Riyad. The question is, what role will artificial intelligence play in enhancing simulation-based education in the incoming years in our courses at International University of Rabat?
Okay, for the first question, we are about reorganization of our curriculum. And as you know, in the next month, we will have a new National Educational Standard Handbook. And in this handbook, we will integrate simulation in good collaboration with the coordinator of models. And I have many discussion with all the teams that carry this program, and we are about integrating the number of hours to integrate in each disciplinary module. And all the colleagues agree with this politic. And for cardiology, for pneumology, for gastroenterology, and etc., will input some hours for simulation on the side of the lectures in the auditorium. Accessibility, about the outcome, yes, there is many papers in the literature which confirm that simulation improve the outcome of patient, that improve the confidence and of practitioner. So this is today. This is evidence. This is an evidence. And what's about artificial intelligence? Yes. We expect to buy some mannequins with the beginning of artificial intelligence in our simulation center, and we will work with the College of Engineering about how can we integrate artificial intelligence in simulation. So far, students have some lectures in auditorium around artificial intelligence and the medical documentation. And in the next future, of course, will be very confident and very sure to introduce AI in the curriculum and in simulation.
Thank you very much, Professor Bensouda, for the answers and for all informations in your presentation. And the last lecture will be presented by Dr. Maio Matos, an anesthesiology department director in Coimbra, Portugal, and past president of CISAB. Dr. Matos will speak to us about the impact and perspectives of the global consensus statement on simulation-based practice in healthcare. Thank you, Dr. Matos.
Thank you. Thank you very much. First of all, congratulate Morocco team for the amazing organization of this really enthusiastic event, and also to thank the invitation to present the global consensus statement to our bigger community. I will share my screen now. Okay. Okay. So, first of all, the global consensus statement intention is to align with the simulation community, and more than just to open new perspectives for the future. What we intended to do as a community was also to acknowledge and recognize the work that we have been doing for more than 30 years into a higher level of discussion, higher level of decision making. So my intention during this 20 to 30 minutes is to grasp a little bit how the consensus started, how we developed the process, what is the consensus statement, how we are opening it to the community and to the areas that we really want to impact, and how we are going to shape the new perspective for this consensus. But first of all, how we are as simulation right now. So we already acknowledge, and it's well established, that simulation has a huge impact educationally, but not only pedagogically, but also testing devices, processes, systems, as a tool for quality improvement, research, but also as a starting point for many healthcare interventions. And with that, and with opening simulation to most of the areas in healthcare, we are facing many challenges. And the biggest, probably the biggest challenge is the disparities that we have across the globe, different approaches, different accesses to technology, and also more than technology, how the faculty development it's being shaped. So what we really wanted to access is have a global perspective of the value of simulation, but also how can we impact all communities into one document, and how we can make every simulation practitioners, user, but also decision making be represented by this document that we really want to use to influence the decision making around education. So inequities, diversity, inclusion, but also the impact that this inclusion has on the promotion of new programs related these simulation programs, also with quality improvement and patient safety, which is also aligned with the topic of this event. And before we go to the consensus, let's just reflect a little bit about our context as a global community. And I'm picturing part of the European reality, and every day we see huge shifts on the healthcare resources community. So based not only on the working conditions, but also on the different appeals that we have on the different countries, we see a trend on a very, very fluid path on healthcare resources. And there is a lot more challenges today when we face these challenges in every day in the human resources that we had probably some years ago. And this comes also not only in the number, in the experience, but also in the new challenges that the new generations approach. And more than fighting these new perspectives, the major challenge is to align a common mission and vision to all generations. And when we talk about healthcare, we don't talk just about the healthcare workers. We know that there is a huge shift that it has a daily impact on this. There is many generational changes in the way that we approach our work and our life-work balance, but also there's a huge also changes in the patients that we have every day. So all of these melting pot, this cultural, this genetic melting pot has an influence on the way that we approach and on the way that we teach for these differences. So we have healthcare workers changing, we have our patients changing, but also our hospitals are changing in the way that we perceive what we are doing, not only by the number of interventions we do, but also in the quality assessment of these interventions. So we have a huge pressure, not just for volume, but also for quality, and quality translating not only into safety, but on the impact that our interventions have on our patients. So we have a huge need now to work in team, work as a team, multi-professionally, multidisciplinary. So more than this approach that we have as our nuclear team that we had some years ago, we now have an hospital team where we need to interact. Different disciplines, different professions that are aligned for any patient circuit within the hospital. And more than the circuit within the hospital, we also have changes, and the impact of the environmental changes have also on the way that we approach healthcare and the way that it's also impacting emergent situations that we need to face that also prevent us from keeping the shape with the trend, but also having this, keeping this perspective of the patient field. So we talked about the shift in the healthcare resources, how the system is evolving, how the community and the cultural melting pot that we live everywhere. It's the same if we are talking about Portugal, Morocco, Uruguay, or US. We face the same issues, the same resources shortages, and the same awareness of the patient to solve not only the problem, but also to face a new perspective. Not just intervention, but the recovery of that intervention and the sustainability of a healthy path. So we are facing a shifting world, and not just a shifting world in healthcare, but also a shifting world globally. And this problem is not just solved with money. So the intention of this global consensus was indeed to articulate this global perspective, how we see simulation-based practice, how simulation is crucial to enhance healthcare education, not only focused on educational level and pedagogical level, but all the other areas that we mentioned before, and to address different recommendations align with the different levels of perspective. So we want to achieve not only the simulation users, the educational community and the leaders of that educational organizations, but also the policymakers. We want to acknowledge simulation as an educational and patient safety resource for the healthcare system, more than just for the educational healthcare organization. So to do this, we partnered with SSH, which is the Simulation Society for Simulation in Healthcare, which is the American Society for Simulation, the multi-professional Society for Simulation in US. And this is also a funny story, because most of the time when we talk about partnering, and we had these conversations many times with our congenerates about what can we do together in order to make it more efficient and more productive for the work that we do locally. And most of the time we have a lot of ideas, but after 1 year, the outcomes are not that important. So what we did 1 year ago was, let's just focus on one. And the focus on one would be how we can influence the policy decision, the policy makers and the decision makers worldwide. So let's do a document that could be the evidence for everywhere and for everybody that wants to impact the value of simulation for the different array of perspectives that we have been using simulation. So we did a working group that's starting the first draft, but we didn't want to make this program CSAM or an SSH program. We want to have a program that came from the society and the communities worldwide to the users and the communities also in a global perspective. So we collaborated with more than 50 national societies and networks. We had up to 67 countries represented in this constructions of the document in a structured perspective. So we started the first draft, and we started a sequence of different meetings with these three different time zones of discussion with these collaboration panels in order to achieve consensus about the goals and the aims, about how we are going to achieve these goals and aims, who we are going to direct this file, and how we could make it efficient for the different perspective fields worldwide. So we finished the first draft in March, and we launched the statement in May, in the 23rd of May, with a live session that we did to announce the statement and to announce the publishing of this statement that we are going to talk afterwards on 4 different journals. So what we state in this document is not just the value of simulation, but how we can drive simulation to achieve, if I would say, human goals. We want to reduce education inequity, so we are putting a lot of effort on promoting low resource, high impact solutions. We want to impact our patients, our patient experience. So we want to impact not only the clinical perspective for each specific procedure, but also the processes and the systems, affecting safety culture within our healthcare system by promoting a more broader perspective of cognitive and social skills, making it more efficient to cope with the difference, to be more resilient to changes, to manage complexity, and to manage outcomes on different impact situations. More than that, we also wanted to address 3 different and new perspectives. One is well-being and how we could promote also not just this personal perspective, but also align the work with the life-work balance. We want to promote also not just the value of simulation in the way that we teach, but also in the way that it translates to the safety of the patient. And also, we wanted to address the shifting model that we are facing right now and that we talked before about how we can cope with this changing system, changing demands, and progressive healthcare system that we are working on right now. So this was the global perspective that is on the document. But more than the practicalities, we also wanted to achieve a standard of practice. And the standard of practice not only on the faculty development, on the impact and on the implementation of our programs, but also on the way that we connect with each other. So we talked about the equitable access to high quality access, high quality healthcare. But we also translate that in a way that many times it's not just money related. It's also program, system, organizational related. And this is where we as a community can help and can grow together. And this is why we are promoting a lot of, as we mentioned before, high impact, low resources solutions for the everyday work. We are not talking about developing new technologies. We are talking about making it accessible for all the communities. And this is also aligned with the way that we see the community. So in the way, and we talked about it before, how we perceive diversity, equity, inclusion, and accessibility to our tools, how we can make it sustainable for the next years to come, and how we can change not only individual perspective, but also the healthcare culture. We have many layers and many stages worldwide related to the blame culture, and we need to make it a challenge, a global challenge to change. We really want to make this perspective, this safety perspective, this multi-systemic approach to training, to education, and to safety a mission that is of the global community, not just of me and our colleagues that are attending this session, independent effort. We want to make it a global effort to change in terms of systematic approach. So in our recommendations, we advocate for sure for the benefits of simulations in terms of the outcomes to the patient and the impact that it has on the staff, on the organizational level, on the systematic level. How we could integrate and adopt simulation not only to our learning, but also to our practice. We talked before about low cost and high impact solutions, but we want to achieve a political, strategic, and financial commitment of our biggest stakeholders, our policy decision makers. Because more than just the equipment, more than just the tenders, more than just the research resources, we really need to work together on the faculty development. And to do that, we need to work as a whole to evolve as a group in terms of what are the quality standards of our faculty, how we can approach this certification, how can we evolve in a way of assessing each stage and make it progressible, sustainable, and easy to measure in a long way term. So this is a huge challenge that it's not solved for sure by a document, but what the document does is to start the discussion. So this is a starting point. This is not the end. So this is the version 1.0. So there are a lot to do to develop these new approaches. So we need research, we need cooperation, we need to understand different levels and different perspectives and different cultural approaches to the same issues and to the same problems. So what we do at the end of the document, it's a call for action. A call for action on different layers. A call for action that starts from our simulation practitioners in the way that we must be aligned with the best practice. We must be aligned with our commitment, not only to undergraduate, to resident training, but to training all lifelong, and to use this resource to training in order to promote patient safety. And this connection with simulation along with patient safety is very important for us. We are aiming also to the healthcare system and educational institutions leaders. So we want to achieve the leaders of the hospitals. We want to achieve the leaders of the SIM centers in order to make it acknowledgeable for them to know that it's not just about buying the simulator or buying the mannequin or buying the amazing extended reality solution or using AI to train. It's about committing to training, to education, to develop our education leaders, but also to keep the alignment of these leaders with the best practice. And to align with the best practice, we need to also to be compromised with the development of our faculty. And the faculty development is something that we need to focus on through all these difficult, but also challenging paths. But the third layer that we added, and in fact, this is why we really started the document, is how we could perceive an influence on the policymakers and leaders. So we want to go to the government. So we want to go to the Minister of Health, to the Minister of Higher Education. We really want them to acknowledge that simulation is an education daily tool to promote outcomes and to promote patient safety. And we are using it not just for the educational means, but also to promote a safety environment within our hospitals. And this is something that we need to work together every day, every country, everywhere we are making it effective. So we published this document on 4 different journals, aligning with this cooperation that we had with the different societies. So we published it on the Journal of CSAM, SSH, INAXEL, and ASPI. But, and we started a website where we ask for individual, for organizational, for systematical endorsement of the document. So what we want to perceive is the next stage. What we want to achieve is how we could face a new perspective in education. So this is the ground. So we acknowledge how simulation is used right now, what are the main challenges globally thinking, and how can we impact the system. To do that, we perceived a call for action for the different layers of the system. But now we need to start working on the next steps, on the version 2 of the document. So we need to perceive how can we be more efficient on lifelong education, which is challenging everywhere you go. And all the data, all the research that you have out there says that this is a burden, this is an issue for the safety of our patients. So this is something that we really need to work together and focus together, but also to the challenges of the new technologies. How can we use AI for educational and for safety concerns? What are the challenges that extended reality, virtual, augmented reality offer us? How can we train our trainers and our faculty to use these resources? Why and where these resources are more effective? Why we need to use this one and not another one? And this is important that we debate as a group this criteria, because the change is now, and we are facing a shifting system. And we can only face the challenges if we reflect together, if we find a common ground of solutions, and if we are strong advocating for our common goals. And more than just the AI and the extended reality, there is also how we can work, not only what we need to do presential and what we can do remotely, but how we can, as a group, work remotely to find local solutions. How can we use the data that we have in my department, in my university, in all of the disciplines that I teach, to make it effective for my peer, my colleague that's working in Morocco, that's working in Singapore, and that's working in Australia, in order to make the data bigger, to make it more effective, aligning with the path that we think it's more suitable for each specific problem. So the main challenge here is how can we prevent ourselves for keeping working individually or in small groups and align with a more larger perspective of approaching each specific challenge. So I will finish inviting you to Valencia, which will be our next annual event of Society for Simulation in Europe. We are glad to be part of a larger community. I'm very happy to be in this great event that, again, Morocco Sim organized, and let me again congratulate under the umbrella of Professor Mohawi for his amazing leadership of this society and the excitement that you see in all the meetings they put together. So thank you very much for this invitation, and I'm open for discussion.
Thank you very much, Dr. Matos, for all these very interesting informations and recommendations. You shows us the consensus interest in guaranteeing high quality and equitable education to health professionals. So do you think that we can truly ensure equitable training for all healthcare professionals worldwide? This is my question. Thank you.
This is the vision. I think there is a huge path that we need to follow to achieve that. But the vision would be to offer the same opportunities for the healthcare workers. So we really want to achieve each specific, and that's why we talked about the ethical considerations under it. Because we want to address AI in the way of perceiving inclusion with AI. We want to perceive extended reality in order to understand how can we make it accessible for the community. So this program, these documents, this live system that we are creating, this larger community perspective, what is perceiving is a shifting in our mental model. Instead of just aligning the educational content with the new solutions that we've been offered, and many times there are different velocities in the way that technology evolves and the faculty development evolves, and even the faculty needs evolve. So we want to change this mental model about what we need to make our goals efficient. And starting on the basic. And changing that model, for sure, we are not having an equal system to everybody now, but we are changing the process in order to make it more easily accessible everywhere. And I think this can be something that could be that could have a lot of impact everywhere that we go.
Thank you very much.
I would like to jump on the occasion to ask you a question. And my question is how to apply this global consensus in our practice in real life?
So, on many ways. So if you are a practitioner aligning with an ethical educational perspective, keeping up with the best practice standards, and have a focus on faculty development. If you are leader of a hospital or a sim center or an organization, understanding the value that simulation has translating into patient safety and outcomes, keeping the system aligned with the development, and demand for quality improvement system. If you are a policymaker, what we can do in a sentence is acknowledge and give the resources needed to each organization and to each group of simulation practitioners to make their programs efficient. So I think that there are a lot of ways to put it in action, but there is the second perspective, which would be working together to develop version 2 of the document. So this is really the starting point. And now that we are promoting that, now that we are marketing the document, now that it's live, we need to keep working together, talking together about what it's not perceiving, why it's not addressing the specific community, how can we be supportive of each other? Because in a way, even if we have different means, different financial resources, there are problems that are transversal to each community that we can work together.
Thank you very much. Thank you once again, Dr. Matos, for your presentation. And before I yield the floor to Dr. Derwish, I would like to sincerely thank our distinguished speakers from sharing their knowledges with us and all participants for their attention and patience. Thank you very much.
Thank you very much to Dr. Shiria Carlos. Thank you for the eye-opening presentation. It confirms indeed the saying that the future is today. Thank you to Professor Bensouda Adil for your presentation that showcases the leading role that simulation plays in shaping the future of the curriculum of medicine. And thank you so much to Dr. Mayo Mateos Francisco, a highly respected leader in the field of healthcare simulation, the past president of CISAM, that he led to greatness. And thank you so much for your global consensus statement. And we are all excited for the version 2.0.
Thank you.
Thank you so much for the opportunity. Thank you. All pleasure.
Ladies and gentlemen, last but certainly not least, I have the distinct honor of introducing my mentor, Professor Mohammed Mouhawi. Where should I even begin to introduce him? When discussing simulation or patient safety, it's impossible not to mention his name. As the head of Morocco Sim, he has been pivotal in promoting the use of simulation in healthcare education, not just in Morocco, but across Africa and beyond. His leadership has been instrumental in organizing initiatives that aim to enhance patient safety and elevate healthcare training standards. But his impact doesn't stop there. Professor Mouhawi is also professor anesthesia and resuscitation, an emergency physician, a digital health instructor, and the coordinator of several university programs, including the Diploma in Emergency Medicine and the Diploma in Health Simulation and Educational Innovations. He's also the head of the SAMU Emergencies and an accomplished author of numerous books, publications, and conferences. With such remarkable achievements, it's clear why he continues to be a shining figure in the field. Professor Mouhawi, mentor, the word is yours.
Thank you. Test. It's okay. Test. It's okay. Thank you, Si Mohammed, for this kind introduction. So good afternoon, everyone. To be honest, I didn't prepare any closing remark for this event. Since I have a very bad habit, I never, ever prepare any closing remark for all the events I was the head of. Since most of the time, I let my heart talking instead of my brain. Recently, I have made amazing trip to Palo Alto and spent couples of days with my telementor, Professor David Kaba, at the Stanford University in Palo Alto and at the Lee Kanshi Center. He teach me a lot of things, but one most important thing he told me, you know, Mohammed, when you share your knowledge, the knowledge does not decrease. Instead of this, the shared knowledge makes this knowledge increase more and more and more. And this fact, this is what we are trying to do on behalf of the Morocco SIM. Morocco SIM is a very young learned society. We are celebrating our 10th anniversary and we are trying to celebrate it with the art and the manner. The idea beyond this journey goes back to Prague. I did the trip to Prague over the invitation of my dear friend Francisco and Ingresia, and I met a lot of people. And maybe we are aware about the fact that Morocco SIM was able to organize an international conference. One more important thing, we have established a lot of affiliation, mainly with CESAM, with ABAS, with SOFASIM, with SSH, and with the New Zealand Association for Simulation in Healthcare. And shortly, we will establish another affiliation with the Saudi Society of Simulation and Simulation Society from Singapore. We also established affiliation with Portugal and Spain, and we are very honored about this. We try to make Morocco at the hub, at an international hub of simulation everywhere. One lecture I have attended in CESAM was done by Ingracia. And Ingracia told something very important. He said, rather than talking about simulation, maybe it's time to move to talk about patient safety. And I found this very relevant because everyone says simulation, simulation, simulation. Let me tell you something very important. Simulation is now more innovative pedagogy. Simulation currently is something very ordinary. It's something like a classic pedagogical approach. So maybe I invite all the audience, no more talking about simulation and moving from today to the concept of patient safety. Why? That's why we call our event Training and Simulation on Patient Safety. PES 2024, organized by the Morocco team. During the journey, I was really astonished by the really relevant topics and lecture all of the speakers. We did an amazing trip from foundation of patient safety to designing and implementation of simulation training. And then we've moved to the impact of error, of the human factor in occurrence of error in hospital. And we finish it with the innovation in healthcare and the global statement. So it's time to make some acknowledgement to our speakers. Most of them was the head of National Society. Thank you very much, dear speakers, for your relevant lecture. It was very, very amazing. Thank you for the participants, for your involvement, for your questions. And I hope that the shared knowledge, you can apply it in your real life, in your clinical practice. I would like also to thank our main sponsor, MHS, for your support. We are very grateful regarding this. Before finishing, I will announce you our major upcoming events. So our first upcoming event will surely the third edition of HTIC. So HTIC stands for Healthcare Training and Innovation Conference, which will be located in Oujda. Oujda is a wonderful city in the east of Morocco. And maybe I will not talk a lot about HTC 2025 because you will be very surprised on the level of this edition. Most of the people you have seen right now in this webinar, you will have the opportunity to meet them in person. And finally, I'm very glad to announce you the second edition of PES. PES is about Patient Safety 2025. Next year, inshallah, if we are still alive, on September 27th, 2025. So once again, thank you very much. We were very excited about this event and see you later, inshallah. Bye-bye.